and are allowed there. The chair sees a quorum. We'll call the meeting to order. I think we'll start first. Senator Niskoski, if you'd introduce yourself, we'll go around this way and introduce the members here at the front table, please.
Thank you, Mr. Chair. David Niskoski, Senate District 10, South Bend, and portions of St. Joseph County.
Krista Ricci, Senate Republican Fiscal Analyst.
Ryan Mishler, Senate District 9, North Central Indiana.
Jeff Thompson, House District 28.
Ben Tooley, Director of Fiscal Policy for the House Republicans.
Joe Habig, Acting State Budget Director.
Lisa Ackelbert, Deputy Budget Director.
Ed Delaney, House District 86, north side of Indianapolis.
Fadi Kadura, State Senate, District 30, north side of Indianapolis.
Senator Chris Garten, Senate District 45, all of Clark County and portions of Floyd.
Jordan Lett, Senate Fiscal Analyst, Republican Caucus.
Craig Snow, State Rep, District 22, which is parts of Kosciuszko and Wabash County.
Liza Sherman, Deputy Director, Fiscal Policy for the House Republican Caucus.
Karen Rawson, Fiscal Analyst, Legislative Services Agency.
Thank you. Representative Porter, we'll wait on you to take your time, introduce yourself.
Good morning. I had the furthest to come. Representative Gregory Porter, House District 96.
Thank you and welcome. Senator Mishler.
Thank you, Mr. Chairman. I want to welcome Representative Snow to the committee. He attended more Budget Committee meetings as a non-member than anybody in the history of the legislature, so he is up to speed.
Thank you. With that, we have a long agenda today, lots of hearings, and so we'll get right to the point. First is Family and Social Services. If they would go ahead, please. The floor is yours, gentlemen.
Thank you. So I appreciate the opportunity to present to you all today. I'm Dr. Dan Rosiniak. I'm the Secretary of the Family and Social Services Administration. With me to my left is Paul Bowling, our Chief Financial Officer. And today we'll give a brief overview of the agency, highlight some of the notable accomplishments really over the last couple years that really should help shape the discussions of this fiscal session between you all and the incoming administration. I will also present our current base budget that I think will better reflect how dollars are currently allocated. And I will mention that while we'll be covering a little bit of Medicaid, the vast majority of presentations related to Medicaid and the Medicaid fiscals will be tomorrow in the forecast presentation. So I will be happy to address questions. Some of those may be best held for the presentation tomorrow. Now, the mission of our agency really is, I think, best summed up as we are here to compassionately serve the diverse community of Hoosiers who live across this great state. And collectively, within our agency, we are committed to creating policies and programs that really help and support the health and wellness of those in the state and to give them the greatest chance of reaching their potentials. Now, as you can see here, our organization is arranged as what we would call a matrixed organizational structure. We have 8 on the left-hand side, what we call care divisions that range everything from aging all the way down to our Disability Determination Bureau. And then supporting each of those care divisions are agency directors, including our chief of staff, who oversees areas including our comms, our physical plant, our ledge services. It includes our chief financial officer, who oversees all of our controllers in the divisions, our finances. It also includes our general counsel, our chief information officer overseeing all of our IT systems, our chief medical, and our chief advocacy officer, all of which support each of those care divisions to accomplish their mission of serving Hoosiers. Now, for the last several years, really since I stepped into this role, we have prioritized predominantly 3 areas across the agency. One of those was reforming the Medicaid system in a way that would give Hoosiers more choice to age in their home and in their communities. The other was really focused on and in partnership and largely driven by you all, which was building a mental health system in the state that is better capable of responding to those in crisis, but also preventing crises from occurring. And lastly, also in partnership with you all in the governor's office, has been expanding access and affordability to childcare. I will spend a little bit of time on each of these priorities as we go through some of the individual divisions, but really for the last 3 years, this is what we have been predominantly focused on across our agency, really doing this work with extensive stakeholder engagement. As I mentioned earlier, FSSA is really 8 care divisions. And so I'm going to go through each of those divisions and spend just a little bit of time on some of the biggest initiatives and successes over the last several years. We'll start with our Office of Medicaid Policy and Planning, or Medicaid. Now, this division oversees all of our Medicaid programs, which serve nearly 2 million Hoosiers across the state. That includes the fee-for-service program, and it also includes our 4 managed care programs, which include the Healthy Indiana Plan, or HIP, Hoosier HealthWise, Hoosier Care Connect, and of course the newest addition to the managed care programs, our Indiana Pathways for Aging program. Now the last one, the Pathways program, really came about after almost 4 years of extensive stakeholder design work. We launched Pathways in July, and that program really at the heart was around moving 100 or almost 120,000 Hoosiers who are over the age of 60 and on Medicaid out of a very difficult for them to navigate fee-for-service system that was fiscally unsustainable into a better, more person-centered, sustainable managed care program. That also involved taking what was previously called the aged and disabled waiver and breaking that into 2 waivers that are now based on age. The Pathways waiver is now serving individuals over the age of 60, and that is now overseen by OMPP or Medicaid. And the other, the Health and Wellness waiver, now is for those that are 59 and younger, and that is overseen by our Disability Division. Now, both of these waivers provide home and community-based services that support individuals' ability to remain in their home and community. Since taking over the Pathways waiver, OMPP has also taken over inviting individuals each month to apply for that waiver. As you all know, this was a necessary step as we needed to implement a wait list for Pathways and Health and Wellness after enrollment exceeded the number of slots that we had approved by CMS and after expenditures had exceeded the budget. Now, since July, we have been able to progressively invite more and more individuals each month to apply for the Pathways waiver, and we anticipate really over the next several months having invited or sent out an invitation for all of the available slots that we have. And so we will continue to follow, obviously, that very closely. Another area of focus in Medicaid has really been around providing better managed care oversight. This includes in claims monitoring, looking at creating some uniformity and more clarity on the prior authorization, both in fee-for-service and in our managed care programs, and also focusing on a lot of care and service coordination. Also, as part of Pathways and as passed this last session, OMPP created a temporary assistance fund really to make sure that those providers that were going to be moving from fee-for-service to the first time into a managed care program, that if there were any issues around them being paid that were related to the managed care entities or systems, that we were able to quickly address those and pay those timely. That actually has gone very well. Our managed care partners have worked very closely with us on this. And we've actually not had to pay too many of those out, but not because we haven't had issues that arise. There are still issues that come up every week in all of our programs, but because the managed care entities really closely working with us have really looked to address them quickly and resolve those issues. And we're going to continue to work closely with them as we move throughout the remainder of this year with the Pathways program. As you're well aware, during the federal public health emergency, state Medicaid eligibility offices stopped doing yearly redeterminations. Now, the cost of the increased enrollment was at the time partially offset by CMS, who increased the federal share of the Medicaid payments. But when the PHE ended in April, Indiana, like all states, began the work of returning to the normal pre-pandemic yearly redetermination process. So for us, that meant we would be taking 3 years worth of eligibility work and really pushing that into 1 year. And probably more importantly, what it really meant is that individuals who had never been through a redetermination, or who the last time they had gone through a redetermination was 3 years prior, would now have to once again participate in the process to really make sure that they were still eligible for Medicaid. Now, really one of the things that we were focused on is outreach and awareness so that everyone had a good understanding of what was needed and what the timelines were. And so we did a really aggressive multimedia outreach campaign with well over 1 million communications. And really for us, it was about making sure everyone had an understanding to the best of our ability of what was going to be required and when. I am personally incredibly proud of our agency for this work. We were one of the few states that had a plan, an unwinding plan with CMS that was approved without correction. We were also one of the few states that did not have to pause redeterminations. We were one of the few states that was not put on a corrective action plan during the unwind work. It was a huge effort for us and for our agency. That was largely driven by our leadership and teams in Division of Family Resource, driven by our comms team, our IT leadership, and our Medicaid teams. And together we have returned to the business of usual in Medicaid redeterminations. For the last several sessions, the legislature has prioritized reforming how we deliver mental health across the state. Now, starting on the right side of this slide, you'll see that we first put a lot of concerted effort on improving the service delivery in those facilities that we operate, our state mental hospitals or our state psychiatric hospitals. This work really focused on reducing the wait times for individuals who were found incompetent to stand trial. And as you all know, when that happens, they are committed to DMHA to get those restoration services. And that is incredibly important because during the height of the pandemic, right, when everyone had staffing challenges and we were all dealing with lots of logistic issues, the wait list from the time somebody was found incompetent to they might receive those restoration services could exceed 4 months. And that was unacceptable, in part because why those individuals are waiting, we know they're often waiting in jails, emergency departments, and other places where the service really that are not well designed for really providing those critical services, not just for restoration services, but for the mental health services that they needed. We were also sued on this, but fortunately for us, we had already begun a lot of cross-agency collaborative work and work within our agency to put together strategies that would address the wait list. And really proud to say that within about 1.5 years, we had gone from that 4-month wait time to today of 16 days. And with that also, the lawsuit went away. So incredibly proud of that, and really for the team in mental health and our state psychiatric hospital network, an incredible achievement. Now, another focus for Division of Mental Health and Addiction in partnership with you all has been building a crisis system. One that really has focused on how do we respond to individuals with mental health and behavioral health crisis, but also important, how do we prevent them from occurring in the first place? And so in collaboration with you and supported by Governor Holcomb, we have been able to really be one of the states that has led in this area across the country. We launched Indiana 988 in July of 2022 and very quickly became one of the top states for the performance measures. In addition to the call center, we have been increasing across the state crisis response teams who are able to respond in person to individuals in crisis, and what we call crisis receiving and stabilization centers across the state, which are locations that are not jails and not emergency departments where folks can get acute crisis services to really help divert folks from those less appropriate settings. Collectively, we have built on those and are getting close to being statewide. Right now, we have coverage for crisis teams and stabilization centers well over 75% of the state. But really, the 988 call center, the crisis teams, and the stabilization centers are just 3 parts of a 4-part system. Really, that last part is really moving to a totally different payment system for community mental health services, a system that is called Certified Community Behavioral Health Clinic Model. So you'll see here on the right-hand side the timeline that in 2023, Senate Enrolled Act 1 directed us to apply for the demonstration program and provided financial support really to build out our crisis system, upwards of $50 million a year. Now, we applied for the demonstration in March. We were one of 8 states that were selected in June, and we are on track to launch the demonstration in January. And really what this does, and I'll mention it's a pilot, it's a demonstration, is it allows us to pilot a new way of paying mental health services with 8 sites. We had a competitive RFI, 4 sites. It was open to all. We ultimately ended up choosing the highest proposals, which were from 8 of our community mental health centers. Now, this is a different payment system, a prospective payment system for them, so it is a higher payment, but with that, sites in return must provide higher quality, more accessible, evidence-based services. They must improve care coordination, and really for the first time, give us better fiscal and service delivery transparency. In addition, they must be part of the crisis system and provide 24/7 crisis services. Now, this model, when it's statewide, really will be the most important transformational change in our state's mental health system because it creates, really for us, the framework for a mental health system that you all have called for and that, frankly, Hoosiers deserve. Now, another area of legislative and governor's office priority has been increasing access and affordability of childcare. The Office of Early Childhood and Out-of-School Learning has really delivered on this. Through a number of legislative changes, through the use of federal relief and federal grant dollars, and through regulatory reform, more families and more children than in the history of our state have been able to find affordable childcare. As this slide shows, maybe, a little slow. Give me a sec. There we go. As this slide shows, we've been able to invest these federal dollars to not just sustain providers through the pandemic, which we did quite well, but to really grow the number of providers. And more importantly, not just providers, but to grow by the thousands the number of new child care seats. We were also able to invest these dollars in ways that better supported families and grew the workforce. We were also able to use these dollars to really make significant investments into the overall child care system. That include helping us to come out of a corrective action plan that we had with the Office of Child Care on how we paid and the way we paid providers and set our rates. It involved investing in really streamlining the regulatory process, making it much easier for providers. It also involved increasing income eligibility for those individuals who qualify for vouchers from 127% to 150% of the federal poverty level, and making it much easier for schools to become pre-K providers and providing substantial supports to workers and the businesses that provide this. And as you can see from this graph, these efforts really resulted in some ways FSSA to better able to meet the demand that we knew was always out there for childcare. So we have been able, as I mentioned earlier, to support more working families than we have ever in the history of our agency in both the CCDF and the On My Way pre-K program. As you'll see on this graph, we have seen a 40% increase in the number of children served overall. Now that we have, we've been able to increase and continue to sustain up to this point these families in part through pandemic dollars, through TANF surplus, some carryover, and some other federal dollars. But Indiana, like every state, these dollars will be ramping down over the next year, which means that we will return in the next federal fiscal year to the block grant amount and the state allocation for vouchers, which means that without additional or new dollars, we are not going to be able to support the number of families that we're currently supporting, almost 75,000 children. And with that, unfortunately, we have implemented a wait list, as we recently announced. So without new federal or state dollars, if we return in October to the normal or to the kind of pre-pandemic amount of block grant dollars federally and state dollars, we estimate we can support around 50,000 children in the next federal fiscal year. Now, we're going to obviously be tracking these numbers very closely. We have a dashboard on CCDF vouchers that's publicly available as well. And really we'll follow closely as we go through the normal attrition that occurs every year through reauthorization. And so once we return, hopefully by October, to the population that we currently have allocated funding to sustain, we will then open the wait list back up. We again anticipate that that could really be in the September or October timeframe, but we are going to follow these numbers very, very closely, and we'll keep folks updated on those on our website and otherwise. Our disability division has also been very busy. As I mentioned before, they took over the administration of the aged and disabled waiver for individuals on Medicaid who are under the age of 60. That is now called the Health and Wellness Waiver. They also are inviting individuals each month to apply for that. They have also started to work on how they're going to integrate services now across the other 3 home and community-based waivers that they provide in a way that really over time will create a better, more holistic centered approach for individuals as they move throughout their life. They have also made a lot of progress towards implementing House Enrolled Act 1342, which really creates a standardized training curriculum for direct service workers and credentialing portal for providers. That will really make training a lot more portable for workers and a lot less burdensome for providers, because right now a provider is required to provide that training. If that worker then leaves a month later to a different provider, that next provider has to provide the training again. By having a portal, this will allow providers to really track that training, and they won't have to be providing that anymore for individual employees. They have also really expanded the scope of the ombudsman to better support not just the family support and community integration and rehabilitation waivers, but also now the health and wellness and traumatic brain injury waivers. One area I do think is worth pointing out is that DDRS has made huge strides in its vocational rehab program. As many of you know, this program, like many across the country, had a wait list in place for the last 7 years. In VR, a wait list is really called order of selection. Now, the VR program really was determined to end that wait list, something that actually few states, once they're in it, are able to do. But really by working on increasing staff capacity, modernizing their technology, and streamlining training and onboarding, they have been able to eliminate that wait list as of October this year, which is a huge accomplishment for them, but something even better for the individuals that we serve across the state. I mentioned the Medicaid unwind earlier, but in addition to that work, our team in Division of Family Resource has also continued to make improvements in our TANF and in our SNAP programs that included expanding or extending the certification period for the elderly on SNAP from 24 to 36 months. In the Division of Aging, with the transition of the aged and disabled waiver to Medicaid and DDRS, really the division now has been focused on other ways to support the rapidly growing aging population in Indiana. Now, one part of that is developing a more uniform, faster, and streamlined approach to the functional eligibility that is required for individuals to receive waiver home and community-based services. So in July, we will launch a new process that's called Level of Care Assessment Representative. That will allow for a far better uniform, faster, and a more sustainable assessment process. They are also really focused on improving awareness and services for individuals with dementia, and have recently developed a statewide 10-year plan for helping support communities with our aging population, or which is called the multi-system or multi-sector plan on aging. In addition, which I'll talk about just in a second as well. In addition, they are launching a new adult protective services model with a new vendor that will begin this summer. Now, the multi-sector plan on aging, this has really been an important collaboration with our stakeholders, including and led in partnership with AARP and others. It is a 10-year plan, and really it's focused on better helping communities around the state support the aging population by making our built and our support environments more age-friendly, by making it far easier to get support services, by supporting individuals to better engage with their local communities and their local economies, and perhaps most important of all, by reducing the stigma that is often associated with aging. With 4 years now under its belt, Indiana 211 has really become the state and community resource for individuals in need of services. The community navigators take over 100,000 calls each year, helping individuals find things like food banks or shelters, or to get housing or supports for domestic violence, among hundreds of other services. They continue to collaborate across state government with other agencies. For example, they provide energy assistance line for IHCDA, disaster relief lines for Department of Homeland Security. They help with our child care enrollment. They have lines that also support Department of Health. Now, the biggest change this year really for them has been streamlining their operations, and they did so in a way that really has allowed us to better improve customer service during the peak time of calls, which is really in the middle of the day, Monday through Friday. And finally, for us, our Disability Determination Bureau has continued to provide medical determinations for individuals applying for Social Security. And despite a number of SSA and federal challenges, we continue to be one of the most efficient and highest quality sites in the Midwest. Now, to wrap up, I will briefly go over the current budget allocation for the agency. And really, that will hopefully help you better understand how the current allocation really is spread across these different divisions that we just mentioned. So as you can see in our state fiscal year 2025, our budget was $24 billion, with approximately $16 billion of that, or roughly 2/3, coming from the federal government. The other funds, including $5 billion, include general funds, and $2 billion in dedicated funds, a large portion of which include hospital assessment fees and other provider fees. If you look at how those funds are spread across division, of the $24 billion, 84% or $20 billion of that is Medicaid. And as I mentioned, we'll be providing that Medicaid forecast to you all tomorrow. The remainder of those dollars really are spread across the divisions. DFR is the second largest amount with $2.5 billion. The vast majority of which really is federal dollars for the SNAP and TANF programs. The Office of Early Childhood and Out-of-School Learning had currently $500 million this year. As I mentioned, that has been able to help us support the largest number of families that we've been able to in our history. That predominantly goes to CCDF, plus that along with federal dollars includes some of the pandemic and TANF investments. You'll see our Indiana State Psychiatric Hospital Network, that's what ISPHN represents. That is the budget that helps us operate our 6 state psychiatric hospitals across the state, of which the wait list I mentioned earlier. In addition, we've got Division of Mental Health and Addiction that has $309 million, largely supporting our state substance use disorder and mental health programs. And then the other dollars that are distributed, as you can see there. As I mentioned, this is the base budget and hopefully will help inform you all and the incoming administration as we head into the session and determine the priorities for the 26 and 27 fiscal years. And with that, I'd be happy to answer any questions.
Thank you for your presentation. Questions? Senator Cordora?
Thank you, Mr. Chair. Thank you, Secretary Resniak, for your presentation and for your team. I have several questions. I'll start with the simplest and basic question. If you go back to the budget information or slide, I think you've included the 2.5 billion. I assume this is only the dedicated fund portion of the budget, not the 5+ billion of general funds. Is that correct? So if you see that second line under DFR, 2.5 billion, if you go to the previous slide, you got 2.3 billion for dedicated funds, 5.1 billion from general funds. So is that 5.1 not included because it's part of the general fund, correct?
Most of that $2.5 billion in DFR is federal.
Sorry, most of it is?
Most of that $2.5 billion that is in the budget for Division of Family Resources is federal, supporting TANF and SNAP.
Got it. So that's why it's not included on the next slide, correct? So in total, you got $7.4 billion between general and dedicated funds, the blue and the orange. So that's 7.4. If you go to, so I'm not talking about the green portion, which is the 16.8. So if I go to this slide, I only see the 2.5 billion under DFR. Where's the 5.1 billion? There's a $5 billion not included.
So the 2.5 billion is a combination of federal and state funding, Senator. So when you look at that previous slide in the summary, it would be included in both of those, in the general fund portion and the federal portion of that pie chart that we're showing.
Okay. My second question relates to the CCDF fund and the recent announcement of potentially 20,000 potential children who will not be funded, have to be, it's a projection that by July of 2025 or maybe third quarter. Well, wait, what is the cost for the state of Indiana to avoid the wait list to accommodate the 20,000?
Yeah, on average, and Paul can check, on average, and it's different depending on where they're located and whether it's Amway Pre-K or CCDF, but it's roughly $7,000 per child per 53-week time frame.
So I think a $2 million would be sufficient for the 20,000.
How much?
$2 million.
It would be closer to $140 million.
Are you talking about the state portion or the individuals? So that the match, the state matches some of the federal dollars, correct?
Yeah, because this is a block grant, and you correct me if I'm wrong, because this is a block grant from the federal government, that block grant plus the current state allocations can support about 50,000. Any additional would be all state dollars.
On the state, the federal dollars will not match the 20,000 for that.
They would not go beyond that time frame, no.
And it's costing about $7,000 per child.
About 7,000 per child.
Per year.
So if you do the math.
Multiplied by 20,000, you get $140 million.
Ballpark.
The third question I have on the Pathways program, the Pathways waiver. So I do serve on the Medicaid Advisory Committee. I monitor the dashboard to look at the wait list. I've asked multiple times over the last 2 meetings, what would the cost be to eliminate the Pathways waiver wait list? I still did not receive that information. Do we have a cost estimate for completely eliminating that list? And I understand there are operational capacity issues.
Sure.
I understand the logic of inviting folks and then processing them and all of that. But I'm interested in knowing if the issue was dollars, what would the cost be?
I think the simplest thing we'll be able to get you is, because it's going to depend, is how much right now on average are we spending on an individual just on waiver services? Keep in mind, they're also on Medicaid, so they'll have state plan services. But if we just look at across the board for those over the age of 60, what is a waiver service cost during a waiver year? And reminding folks that waiver is really broken into a year from July to June. I don't remember the number, ballpark, it had it in the $70,000, $80,000 range, but we'd have to give you that. Then it really depends on demand. When we say how many to eliminate, it's going to depend on how many more people apply over the next year. Correct. But we'd at least be able to give you a number where you'd say with 20 million, that on ballpark would get you X number of additional slots that you would have versus.
And I appreciate that because this is a budget committee meeting and I've requested this information multiple times and I have not received it. It is extremely important for this committee to understand that cost with the assumption controlling for where we are today and not just estimating for the future. My concern with this is that while, FSSA correctly articulated that these slots are approved by CMS, there's a step that was not articulated publicly that is the responsibility of FSSA, and correct me if I'm wrong, which is the idea to project and to estimate how many slots we need based on the aging population. Then FSSA submits those numbers to CMS, and then CMS approves. So the missing spot or the missing piece or step that we have not been discussing publicly, and that's why I'm asking that question, is that if it's a fiscal constraint because the state of Indiana is not fully funding the wait list, we need to know that number so that we can have these debates during session. I fully understand if you come to the General Assembly and say we need 70,000 slots, and then the response is we can only fund 50. I understand that. But I want to know what is the full cost to be sure that these senior citizens are not placed for months and months and months on a wait list. I understand they do receive the waiver program, Medicaid program services, but not the waiver services when they are waiting on the wait list. So I'd really appreciate it if, as soon as possible, if you can send us that. The last question that I have deals with the HIP 2.0 and with the half or the hospital assessment fees. With the recent news about potentially the 2016 law, the trigger law, and what the state, if the federal dollars don't come in, where are you in the negotiation process with the hospital assessment fees, and how much should we be concerned about the idea that HIP 2.0 could go away?
Yeah, it might be a better question also to talk with Medicaid Director tomorrow, but I think for sure all states are looking at if the FMAP changes and states have trigger laws, so to speak, in place, that would obviously be a concern. But really for us, in terms of the half, we've worked with the Hospital Association and we'll continue to work with them and with you all as to how we might kind of work the current hospital assessment fee in a way to better support hospitals. I would particularly say to make sure really in addressing those critical access hospitals and those rural hospitals that I think are at the greatest risk if we lose expansion population.
So at this point in time, are you concerned that the HIP 2.0 could potentially go away?
Yeah, I think ultimately that's going to be up to you all.
To the General Assembly to fund it or not? Okay. Would you add one more question to the list of information to submit to this committee, which is based on your half or the hospital assessment negotiations, if the FMAP or the federal match is not at the 90% level, would you be able to provide us with the information, the gap between the hospital assessment fee that is needed and general fund dollars that are needed to be sure that the HIP 2.0 program can continue?
Yeah, I don't know how, we need a little, we can certainly look at it. It would take more questions and answers really to figure that out. So it would be, what does it go to, what percent, if it goes from 90% to 85, what is 5% equal? And then we'd have to have discussions as are the hospitals, because there's also, half is also written into statute as well, and how does, if it changes, how does that affect that? So.
What is the deadline for negotiation with negotiating with the hospitals on the half assessment fees?
What is the what?
The deadline.
Oh, I don't know that there's a specific deadline.
Okay, thank you. Thank you, Mr. Chair.
Thank you for the questions.
Thank you.
Any further, Representative Porter?
Thank you, Mr. Chairman. Thank you for your presentation. Just a couple of quick questions to follow up in regards to the senator's question. Excuse me, how much is the state match for CCDF? We've tried to get that information before.
How much does the state appropriate towards the child care programs?
Yeah, I can definitely grab that. So you're talking about what state share we put in for the CCDF program? Yes, I will get that for you, Representative. I do have that information from that standpoint.
Can I get a time frame to get that?
Yes, I mean, it'll definitely be this week. I could get that to you, Representative, because
Okay.
I have that information.
All right, thank you very much. Another question, slide number 16. Excuse me, thank you. You're talking about the vocational rehab.
Yes.
At one point that we elected as a state not to take the $9 million from the federal government. Are we getting all the dollars we can from the federal government to do the vocational rehabilitation program?
I don't know that I have enough information on that.
So you're referring to, Representative, if we're leveraging all our current federal grant dollars available to us?
That is correct.
Currently, with our state appropriation, we're not able to leverage the full grant amount. from that standpoint. We are using the grant funding that we're able to leverage with our state funding currently at this point.
So we're not able to leverage those federal dollars?
I mean, we're able to leverage everything compared to the state appropriation. So based on the state appropriation we have available, we're drawing down all the federal dollars that we're able to with those dollars.
Okay. That's something that we need to think about some more. Thank you, Mr. Chairman. Appreciate it.
Senator Delaney? Representative Delaney, I apologize again. I've done that more than one time this year.
Thank you. I'm very concerned about the Governor Pence's program to expand Medicaid, and I believe implicit in your remarks is that it has helped our rural hospitals. Is that a fair assessment?
I think it's helped all hospitals.
But including the rural hospitals?
Sure. I think if you look, where are the highest percentages of individuals that receive Medicaid services, you're going to have the largest numbers are obviously going to be in urban areas because of population density, but obviously in rural areas as well, those hospitals depend on those.
And how many rural hospitals are in danger of closing if we don't continue Governor Pence's program of Medicaid expansion?
Yeah, I don't have that an answer to that.
I take it that's a legitimate concern that this could happen.
Yeah, I think that would maybe be a question that Department of Health might know in terms of.
So you don't know?
I don't know.
Okay, so I should ask the Department of Health, okay. And something that I guess I can ask you is at page 4 of your transmittal letter, you make several comments that are of interest to me that I wanted to get into. Specifically with regard to the CCDF and the On My Way Pre-K. It's true apparently, and I'm looking at page 4 under OECOSI, if I can read, that you're getting many more applications than there's available funding already for the school-age kids grants. Is that right?
Yeah, we currently have, that's correct, Representative, we currently have a wait list, meaning there's more people applying right now than we're going to have funding to support.
Did you have that wait list before you just inaugurated the wait list you announced last week?
No.
Okay, so the only wait, you have one wait list for, is it for On My Way Pre-K and CCDF?
Yeah, it includes both.
That includes both, okay. So what's the pool that's at risk? How many children might not get one of those services because of the wait list?
Right now, with the dollars that we have appropriated this state fiscal year, we are serving upwards of 75,000. When we return to the next block grant in February or in October from the feds, plus the dollars that we have state appropriated, we'll be able to serve about 48,000 children. So roughly 25,000 children difference between current being served and where the appropriation would allow.
And how many families would be impacted by that?
I don't know. We might be able to pull those numbers because it depends on how many children in a family are currently receiving vouchers.
And it's costing us about $7,000 on average for a child. Is that in either the CCDF or the On My Way?
No, that's an average between those. On My Way Pre-K is a higher cost, in part because the services and the Pathway to Quality program results in a higher payment for those level 3 or level 4 quality services. CCDF is generally a lower cost.
Have we lowered the requirements for the level of service requirements for the On My Way Pre-K?
No, we haven't changed the Path to Quality program, the quality program.
And lastly, your fiscal numbers don't seem to help me because you used a base number, right? You've not given us any estimate of what your budget will be for next year.
That's correct.
You've simply reported, in effect, what it has been in the past. And one last very specific question. If a child, let's say in next month, goes into foster care, will they be put on this wait list for On My Way Pre-K or CCDF?
Yeah, all children will be currently on a wait list until either we return back to the number that we can support fiscally.
So in that specific instance, the willingness of people to take a child on will be reduced, will it not?
That's correct.
Okay, that's something I hope you'll work with us to avoid. Thank you.
Senator Mishler?
Thank you, Mr. Chairman. So in '23, I had members come to me and say, in the On My Way Pre-K, we had a balance. We weren't spending all the money, so let's change the eligibility. I was adamantly opposed to it because I knew we'd be sitting here where we are today. So had we not changed the eligibility in '23, would we still be short today?
We would still be short today. We have certainly increased the number of families by going from 127 to 150% of federal poverty level, plus we had the worker prioritization. That has definitely increased the number of families who are getting services, but the largest percentage of those that we support are still those that make less than 100% of federal poverty level. So even without that, we would still
be short, but the
not
wait
as
list
short.
wouldn't be as
Correct.
large.
That is absolutely correct.
Okay, thank you.
Thank you. Further questions? Representative Porter? Yes.
Thank you, Mr. Chairman. Just a comment. In regards to Representative Delaney and asking about the hospitals, I've had some conversations with some administrators. I know there's been a change in hospitalization efforts in Fayette County, rural Union County, and some hospitals have closed, but I think the services have been cut back, particularly in OBGYN area. And it seems like to me, and talking across the state to some administrators, that our rural hospitals are not really being able to house individuals, but more turning to like emergency type rooms, emergency type hospitals. And so I'm just very concerned about that, that our rural, even though I'm an urban, but represent the whole state in my own window, we need to be really concerned about what is occurring in our rural hospitals and the impact of what we're doing. Thank you, Mr. Chairman, for allowing me to make those comments.
Further questions? Thank you for your presentation.
Thank you, Chair.
Next up, Department of Child Services. Ladies, the floor is yours when you're ready, so.
All right, good morning. Sarah Sailors, Chief Deputy Director, Senior Advisor for the Department of Child Services. I am here because Director Miller is on medical leave, so I will be presenting for him today. And then also with me is Jasmine Williams, our CFO. So to begin, I wanted to remind the group that in 2023, we refreshed our vision, mission, and our value-based principal practices. While many items included in the practice model stayed the same, such as our mission and vision, and the practice skills that we use, as you see up there, the TP skills, teaming, engaging, assessing, planning, and intervening, it was necessary with a change in leadership to refresh our values. We worked with an internal team, external partners to identify the current agency values. Through that work, it was clear that we all agreed on our top 3 priorities: child safety, child permanency, and supporting our foster and adoptive families. Child safety is our top priority at DCS. It is the center of everything that we do, and we are constantly reviewing our practice and policies to ensure we do everything possible to uphold our responsibilities to the children in Indiana. Our hope would be that a child never needs to interact with the Department of Child Services. But unfortunately, thousands of children each year are victims of abuse and neglect. Once they come into DCS care, our goal is to ensure they have stability and support, and that we are doing everything possible to get them to the right permanency outcome as quickly as possible, and that we are supporting foster and adoptive families in their journey. Along with a focus on child safety, reducing time to permanency has been a top priority for the agency. We've made progress in those efforts, seeing the median time of permanency decrease by almost 8%, or 1.5 months from fiscal year 23 to 24. We further believe that House Enrolled Act 1369, which provided a major overhaul to Indiana's termination of parental rights, or TPR, law, will have a direct and significant impact on time to permanency as we move forward. The new provisions in the TPR law added timelines, and it equipped DCS with increased opportunities to provide clear evidence relating to a biological parent's actions or inactions. These provisions address concerns often reported to the department as they relate to the length of time afforded to parents while children linger in care, repeat removals, and how the department can address egregious cases. House Enrolled Act 1369 helps us build stronger cases. We know that when a TPR is unsuccessful in the court, DCS must restart its entire case, meaning the efforts to reunify start over, which delays permanency for that child. As of September of 2024, we have filed the TPR petitions under every provision of 1369 with the exception of subsection 11, which applies to when a child is conceived as a result of a specified crime. Additionally, we have cited the new provisions in filings or draftings more than 300 times since the effective date of 1369 in March. While we're monitoring outcomes of cases that have been filed utilizing the new provisions, as of this time, we have not been taken up on an appeal and have none that have yielded any applicable case law. House Enrolled 1369 has given us significantly more opportunities to advance permanency. We do not have a complete picture yet of just how impactful these provisions are on permanency, but we'll share that information once we have a year's worth of data. To further support permanency, in July of this year, we made program changes to ensure that Indiana families who provide a child in foster care system with a permanent home through adoption or eligible guardianships received the subsidy equal to 100% of the amount provided while the child was in foster care. Formerly, adoption subsidy negotiations added a month and a half of time before a child achieved permanency through adoption. Nearly all of those negotiations have now been eliminated. By making assistance more readily available, we're working to address the financial burdens of those who would otherwise be willing to open their heart and homes to support families by encouraging adoption and other paths to permanency for children. By ensuring that adoptive families receive appropriate financial supports, we can move children into permanent living situations in a more timely fashion. Some of our accomplishments from 2024 include launching the quality assurance team around safety. In mid-2024, we launched a safety quality assurance team to review our unsubstantiated assessments to determine the quality of our decision-making in real time in order to implement quick changes and identify opportunities for additional education and training. Since its inception in Q2, the team has reviewed more than 1,250 assessments and made changes to policy and practice as a result. The team also developed 2 comprehensive scoring tools for in-home CHINS cases and informal adjustments. Intensive foster care services is another area we are extremely proud of. We've seen tremendous growth in this area of children with high acuity needs. Indiana defines children with high acuity needs as those who present with at least one of the following behaviors: violence, aggression, elopement, defiance, maladaptive sexual behaviors, property destruction, self-harm, or substance use disorder. These children often have multiple diagnoses, a history of placement disruptions, and/or intellectual and developmental disabilities, as well as behavioral and/or mental health needs. Due to safety concerns, a higher level of need, and the requirement for intensive services, past interventions and services offerings have not been sufficient to meet this child's unique challenges. DCS has closely collaborated with FSSA and the Governor's Office over the past few years to improve support services and treatment options for youth with high acuity needs and their caregivers. To help address this urgent need, we developed a rapid response team, or you might hear it called RRT, that provides cross-agency emergent case support for children with high acuity needs and identifies emergency placement options. When these children have needs that are going unmet in their current settings, the RRT problem solves on an emergent basis to identify the best possible outcomes and next steps for that child. The collaboration also resulted in us putting out an RFP and launching intensive foster care, also known as IFC, which is designed to support caregivers of children who have experienced placement disruptions or have overstayed recommended timeframes in residential or group care settings, often in resulting in recommendation to be placed in foster care. The goal of intensive foster care is to place children in a single placement to encourage safety and stability while supporting the caregivers and children in IFC with appropriate additional services. IFC provides foster care services for children who require a higher level of need. The program launched on November 1st, and more than 4 children are either already in the program or have been referred to and are awaiting caregivers. We have at least 2 providers in every DCS region of the state. We have also been working to improve our relationships with foster and adoptive parents. One of our strategic goals is to improve this relationship. We've been working on this in several different ways, including increasing awareness of the Foster Parent Bill of Rights among our staff. Starting this year, we required division managers, local office directors, and regional managers to meet with at least 1 foster parent per month. These discussions with foster parents provide informal and formal information with statewide leaders collecting data on at least 8 questions. The data helps us provide additional insight into the items that support foster parents, including policy and practice changes. I would like to shift our focus onto some of our key metrics. Looking at the front end of our system and talking a little bit about our hotline reports. This is our public-facing tool we use to receive the reports of child abuse and neglect and facilitates and fast-tracks connections with local offices as needed, regardless of the time of day. Our hotline is staffed 24 hours a day, 365 days a year. Only 3 states have a higher rate of abuse and neglect reports to their child abuse and neglect hotline than Indiana. As part of the hotline's quality assurance review, the hotline consistently scores high in key categories, such as information gathering, decision appropriateness, documentation, and customer service. The average speed of answer has been at 30 seconds or lower since 2015. The hotline handled more than 214,000 reports in state fiscal year 2024. The vast majority of reports are calls to the hotline, but they can also include faxes, emails, or mail-in reports. When we look at our performance for calendar year 2023, we had nearly 200,000 calls alone. The average speed of answer for law enforcement was around 16 seconds. The average speed of answer for non-law enforcement calls was 22 seconds. On average, we took 626 calls on a business day and 219 calls per weekend. After our hotline takes those calls, we then look to what we call an assessment. And as you can see, we peak around the months when school is in session. Schools are one of our main reporting sources for cases of abuse and neglect, so we tend to receive more reports during the school year. We screen in about 60% of those reports each year. Those that are screened out, they either don't meet statutory definition or fall outside of DCS jurisdiction. For instance, an alleged perpetrator must be a parent, guardian, or custodian, and the alleged victim must meet the age requirements in statute to fall within DCS jurisdiction. If they do not fall within our jurisdiction, we will refer those to law enforcement. We also find that residential providers may be overusing the hotline to report incidents when a child falls down, scrapes their knee, needs stitches. Those aren't necessarily abuse and neglect reports, but it is how currently the system works to get us that information quickly. And so we are working collaboratively with our residential providers to find better ways to report that kind of information and right-size our front end. Each new case that is screened in is in addition to a caseload an FCM is already carrying. Assessment FCMs are supposed to carry 12 cases by statute. Approximately half of our FCM need is for assessment caseworkers. Per statute, when an assessment is screened in, we have either 2 hours, 24 hours, or 5 days to see the alleged victim or victims face-to-face. Each report can have multiple victims. On average, we open 8,700 new assessments each month, and we have 40 days to complete that assessment. At the end of October, we had screened in 95,826 new assessments this year. Number of children in DCS care. As you can tell, it has slightly increased over the last year. The total number of DCS cases includes children in need of services, which can either be in-home, children being served in their own home, or removed and placed outside of their home with foster families. They can be in relative care or in specialized treatment centers. Informal adjustments, otherwise known as IAs, is a voluntary program of care, treatment, and rehabilitation that requires court approval and oversight, but allows children to remain in their home while families receive services. And we also include older youth services, which serves youth 16 to 21 who receive focused independent living case management to help them transition successfully to adulthood. For youth age 18 to 21, collaborative care is a voluntary program that allows DCS youth who are 18 to 21 to remain in DCS care and continue to receive services. Of that previous group, a subset of children is children in foster care. We place a high value on ensuring that children who must be removed from their biological families due to safety concerns are able to maintain stability. We've seen a significant increase in kinship care or relative placements over the past 5 years, which we believe benefits children by maintaining those close connections. Currently, nearly 55% of children are placed with relatives, while about 39% are placed in traditional non-relative homes. Kinship placements represent a 20% change in 5 years, and we feel that that positively impacts children. The remaining children in care, around 6%, are in residential treatment facilities or other settings such as acute hospital care. In 2024, one of our agency goals that I spoke about was to improve time to permanency. As you can see, we've made strides in the right direction. We know that House Enrolled Act 1369 changes to statute requiring concurrent planning at 12 months and adoption subsidy negotiation changes have all contributed to this improvement. We believe and know that we must continue this progress. It's important that the partnerships between the courts, DCS, and policymakers continue. Okay. None of this can be done without our family case managers who carry all the caseloads. Statute requires us to maintain a certain level of staffing among family case managers to keep caseloads manageable and to better serve children and families. The 12-12-13 statute calls for 12 active assessments relating to initial assessments, including investigations of an allegation of abuse and neglect, 12 families monitored and supervised in active cases relating to ongoing in-home services, and 13 children monitored and supervised in active cases relating to ongoing services who are in out-of-home placements. In June of 2023, we were at 99% of the standard statewide, but we've fallen significantly since then. In June of 2024, our compliance rate was just above 92%. And in October, we're just above 88%. As you can tell, one of our biggest challenges as an agency is our turnover. The turnover among family case managers is significantly higher than our agency-wide turnover rate, which has been declining over the past 3 years and is currently at 24% annually. Our family case manager turnover rate has averaged 36% over the last 3 years. When a case manager leaves, that can contribute to delays in a child's case as a new FCM gets up to speed. This creates knowledge gaps, which lead to less timely permanency. In fact, an often cited study from Milwaukee County notes that fewer changes in caseworkers increases the chances of timely permanency for children. High FCM turnover means that we must continually be working to hire family case managers to maintain compliance with the caseload standard. We cast a wide net in our search for candidates utilizing platforms such as Indeed, sponsored job post, non-sponsored job post, college fairs, social media, you name it, we've tried it. We even launched a statewide marketing campaign to try to help recruit candidates this past fall. Oops, sorry, let me go back. Sorry. Another area that we need to focus on is recruiting and retention of our foster parents. We consider many factors when placing a child in care in the least restrictive environment that appropriate meets the child's needs. We often find we don't have available foster homes in counties where they're needed, which requires us to place children outside of their home county, or even sometimes means separating siblings, which is something we try to avoid. And as we see the increasing trend of children entering care with higher needs, foster parents are often unwilling or ill-equipped to foster, leading to more frequent placement changes or out-of-county placements. Retention activities for our foster parents are underway, with more frequent and purposeful home visits by foster care licensing specialists to foster homes to help address stressful situations and help foster families navigate these complex needs and family functioning. Additionally, field leaders are visiting the homes monthly, recording the identified pain points for families in their county to work on local strategies with their case managers and their community wraparound providers. We hope to better equip foster parents, and we're currently in the process of designing our in-service training to better meet the unique needs of each family. We believe more resources and education will better equip our foster parents, instill higher confidence in their ability to care for their children, and reduce placement disruptions. We have long identified the need for increased rural foster homes and rural resources. We've been partnering with private licensed child placement agencies and faith-based organizations to embed in foster home systems and to provide the concrete supports that they need, as well as social and emotional outlets that connect existing families to one another for support and mentorship. We're struggling to access treatment for our high acuity youth. While the number of youth in residential care has declined significantly over the years, finding high quality in-state residential treatment for those who need it remains challenging. DCS often finds itself trying to find placements for youth whose needs are often better addressed by other state government programs and services before DCS intervention becomes necessary. But DCS is one agency that cannot turn youth away. Collaboration among state agencies is essential if we are to best serve Indiana's youth. This is why the collaboration between DCS, FSSA, DOC, DOE, and the Governor's Office to address children with high acuity needs is so important. At this time, I'll turn it over to Jasmine, who will give you a fiscal overview.
All right, switching gears to the department's budget and finance. Let's see, is it which one do I?
Is that to the right? Yeah. Maybe.
Sorry. Okay. Switching gears to the department budget and finance. Here you'll see that over the past couple of years, the department has operated a budget of roughly $1.3 to $1.4 billion. I do want to specify that while it says DCS funding sources, this does represent our spending. And on this slide, for the federal piece, our state match portion is included in that, since that it's moved over to the federal portion there. Okay. On this slide here, we broke down our expenses by type. By large, our greatest expense at the department is our direct services to the children and families that we serve. That's represented there, about 65%. Next greatest expense category would be our field and legal payroll. So that's our FCMs, our family case managers, and those lawyers that are out in the field. And then you see here support staff, that's everyone that's not field, comes in about 4%, and our administrative expenses, 9%. Admin expenses could be anything from our leases for our local offices and other administrative contracts there. Oh. Right. So to close out the last fiscal year 24, the department required an augmentation of roughly $38 million. That augmentation was to our Family and Children Fund. That fund does cover direct services to family and children that we serve. What led to that increase, as Sarah mentioned briefly there, we did see an increase in cases, about 15% from fiscal year 23 to fiscal year 24. Our out-of-home services increased by $54 million. That would include your residential, your foster care, and your community-based services. And for this fiscal year 25, the department is projected to request another augmentation of roughly $70 million to close out this fiscal year as well, largely driven by those same factors that we saw in fiscal year 24. And then at the bottom here, we just broke out so you can see the different categories and an increase in spend. These expenses in this chart do represent both state and federal participation. So with that, we are happy to turn it over and answer any questions that you may have.
Thank you. Any questions from members of committee? Yes, Senator Mishler?
Thank you, Mr. Chairman. So I know this year they augmented 30 million, and next year, this next fiscal year, you're looking at 70 million. So why are you coming up short in your budget?
So thank you, Senator. That is largely due to the increase, frankly, across the board. We've seen increases to our services. The largest increase happened in that out-of-home category. So that would be your residential placement, your home foster care. Those trends are still moving that way. There are factors that go into that. So our utilization in that area, so that's bad days that we pay for, has increased roughly 3%, but also you have rate increases that go into that, some of which we did request funding for in the previous budget. So community-based services, we projected about an $18 million fiscal impact last budget for that, for the out-of-base community services. Of course, that estimate changes based on the actual children served and the children that do receive that. And then on the probation side as well, the department, we don't make placements in probation, but we do pay for their placements there. So if you see an increase in costs for residential placements on the Chin side, you're going to also realize that on the probation side as well. We pay the same for the bed, regardless of if it's a Chin's child or a probation child. Yeah, so those are the main categories where we saw the increase. We also have some slight increase to our in-home. That would be our family preservation model as well. I believe of the 15% increase in our cases from 23 to 24, majority of that was in our in-home area. Sarah, if you correct me if I'm wrong, if that answers your question.
So you're showing all these efficiencies, so I would assume that the number of cases is going down. You're telling me it's going up.
This past year, we've increased. I would also add to Jasmine's notes that the acuity of youth, right, has gone up. We see youth coming into care with higher level of need. And so when you have a higher level of need, we're paying at a higher rate for that, to meet that need. So I think even though the number of children going up hasn't increased a significant amount, it has increased over the last year. The amount we're paying to meet the need per child.
So the average
is up.
cost per child is what's
Yes.
going up, is what you're saying?
Yes.
Thank you.
Thank you. Further questions? Representative Delaney?
Yes, the number of calls that you have with potential abuse is stunning. How do we compare to other states?
I don't have other states' data with me currently, but we are a high-volume state. We know that. We have a broad definition of parent, guardian, custodian compared to other states. We have a larger purview sometimes compared to other states. So the way our statutes and what we are required to investigate is large. I think we are effective and efficient on the front end, so people use us like they should, right? And they have a good experience, so they're willing to call back and call again.
The caller typically doesn't know that our statute is broader than that in Ohio. So just on the gross number of people who think they ought to call our state and say they have a child being abused or they've seen an abuse of a child, how do we look compared to other states? Set aside those technical definitions.
Sure. Yeah, I mean, I think we have a high volume compared to other states, but I don't have those numbers off the
Okay,
top of my
I
head.
mean, that's obviously very, very concerning. You also interestingly distinguished between calls from, say, friends or neighbors and calls from the schools. What percentage of those 250,000 calls come from somebody associated with a school, meaning the principal, the teacher, the guidance counselor, whomever?
Yeah, schools, law enforcement, and hospitals are our #1 report source. I don't have the percentage with me, but I can get it to you.
That would be, I think, very
Yep.
informative for us. With these wait lists we're now going to have on preschool and on daycare, in effect, for smaller, younger children, is that going to add to your problem in finding foster parents and adoptive parents?
I do believe that there will be an impact to the agency in terms of willingness to foster, right? Childcare is expensive and it's hard to access. And so I think if we have really appreciated the collaboration over the last several years to get our foster parents access to those vouchers and so that they can continue to work and do what they need to do. But willingness to foster is already a problem. And so it does concern us that that will impact it.
I want to thank you, by the way, for noting this projected augmentation. Your agency distinguishes itself by openly telling us that you're, I'm going to use a gentle term, you're somewhat underwater, okay?
Yes.
And you want to be funded. So I respect your decision to do that. I wish we saw that from more agencies because we're not hearing that information. So I wanted to congratulate you on that. The turnover issue is the last issue. About more than a third of your direct service professionals who deal with children in need leave every year. what can we do that might alleviate that, that might reduce that pressure? Is it pay? Is it benefits? Is it, what is it that we could do, if anything? Is it the fact that our universities or colleges are not turning out people who, specialize in this, who are interested in this? Just what could we possibly help you with on the turnover issue?
That is a very heartfelt question, and I struggle every day to try to figure out how to support our front line, right? They are 24/7. I mean, we were just able to give them a waiting to engage pay, which has been fantastic. So when they're on call, historically, we didn't pay them. They just waited, right? And when you're called out at 2 a.m. and you got a 2-hour response time, you got to get up, get your kids, some childcare and find a way to get out there. So paying them has been a huge step in the right direction. I think we've increased our pay for them. Of course, the secondary trauma that they experience with the things that they see, sometimes the pay isn't worth it, right? And so finding ways, I feel like I have to work really hard to find ways to help support them. To workload capacity is high, right? And so I don't know that I have a magic answer today. I think we've implemented, I'm really proud of the worker to worker program that we've been able to implement with your support. And we've partnered with Rutgers University to hire retired caseworkers who are available to consult with our caseworkers when they need somebody to talk to who's walked in their shoes. And I think we've just launched that, and I think that will be a big support to our staff.
There seems to be, there's this massive push here for internships and career and technical education, but your staff generally have a degree, right?
So we've recently changed that to try to expand our workforce. So there is an exception to the degree requirement, and it's on a scale. So you have to have so many years of work experience to be able to potentially be hired if you don't have a degree.
But are our high schools, our Ivy Tech, our colleges, universities, public or private, are they working with you? Are they cooperating with you? Because I would like to see young people who are interested be confronted with the realities so that they show up, they stay.
Yeah.
But are they working with you?
Yeah. We have good partnerships with our schools of social work across the state. We do bring interns in. We have interns, whether they're BSW interns or MSW interns. We also will take interns from other disciplines, whether they're studying, psychology or sociology or even education.
Well, good. Keep up your efforts, and thank you for your forthrightness.
Representative Porter.
Thank you, Mr. Chairman. Thank you, Ms. Saylors, Ms. Williams, for your presentation. I have just two quick questions. One question is, I know there was a conversation reported that there were children that were sleeping in DCS offices. Is that still occurring, or how is that going?
That's a great question. So the high acuity and the needs of the children, right, the aggressive behaviors, those kind of things, make it challenging for us to find placements right away. So we have had to have children in our offices overnight, and we're staffing those. We require at least 2 staff for every child in the office, right, so that nobody's alone with the kids. We created, internally worked with our IT department to be able to see how many children are in our office at any given time, and to be able to alert. I get an email myself if a child has been in the office more than 23 hours so that we can help triage those kids and try to find placements. So we collect data now on the demographics of those kids, like age, sex, needs, so that we can then use that information to work with our community partners to find services to meet their needs, right? Whether it's treatment options, And so then we partner with a residential to build out programs, but it's slow. I think, I can't give you on average how many a day, but there are nights we don't have any kids across the state sleeping in any offices. And then, there might be a morning where I wake up and I've got 6 emails, so 6 different children across the state. I know down in what we call Region 16, which is like the Evansville area, we tend to have a higher need for foster homes down there. And so we've seen more children in the DCS office down there. We've also been, I think, grateful and to Isaiah 117. Have you heard of that program? But it's transitional houses where volunteers come in and they'll stay. Our kids can go to the office, to this house, stay with the volunteers while we sit there and work to try to find placement, make calls. So that's another way we've been able to keep them in a more home-like setting out of the office, because, our office is our office, right? It's desks, it's not a place for kids. So we're trying to get creative to find lots of ways where we can keep them in better places, but we still have a higher need for foster homes.
Okay, thank you. Other question, follow-up question, is in regards to kinship care, you've reported, I guess on slide 10, there's been a nominal increase of assistance. Do you think we need more dollars going toward that for individuals to have more kinship care for families? Because if you're a grandparent and you have a fixed income, then you wind up with 2 or 3 children. It's just it's hard on the family.
It is hard, and it's
and I think it's important that overnight, et cetera.
Yeah, we in July. August, we were able to start supporting our kinship caregivers, and so they receive a stipend of $300 per month, and that has helped us, one, stabilize the relative placements that we do have, and then 2, more relatives are willing to take on, right, with that, that support.
Is that $300 per child?
Yes, per child.
Okay.
And to specify, that was last August 2023 that we rolled that out.
Oh, yes.
Thank you. Thank you very much, Mr. Chairman. Thank you very much.
Further questions? Senator Cordora?
Thank you. Appreciate it for your presentation. I have 2 questions. I'm looking at the agency operating account document. I'm not sure if you have this or not. Looking at federal dollars specifically, can you tell me, out of the Department of Health and Human Services funds, do you get directly from DHHS or from the Social Security Administration, do you get the supplemental Social Security income for each foster child directly that is spent on each foster child, or are those dollars intermingled in your budget and just spread across the cover overall agency expenditures?
So the way it works for us, and I do believe we are in a majority, I can get you that exact number, but I think about 30-ish states operate similar to Indiana. When we receive those SSI payments for the child, they do go into a DCS-specific fund. It's an isolated fund. It's not reverting. It does not go through the budget process. It's a dedicated fund that's non-reverting. We do track it specific to the child in our Kids Track system. However, we don't set up individual accounts per each child.
Got it.
Historically, we have used that funding to cover costs to care for the children. And we can also provide what that has looked like over the past several years as well. I will say, because there has been lots of conversations about that nationwide, we are in a majority, but the past fiscal year and a half, we have not transferred any funding or expenses to cover the needs, what we spend to care for those children. But historically, we would when we have shortfalls there or need to.
So generally speaking, it's a dedicated fund.
Yes.
Does not intermingle with any other funds.
Correct.
Even though the dollars come in for each child, the pool of money is used for that pool of children.
Yes.
Not specifically for does not go for children's accounts like segregated
That is
separate
correct. It
accounts.
is used for the department's total cost of care for kids.
And which line item on your agency operating report would that be included? Would that be under the federal fund, or is it completely separate?
So that's not on our O1A report because we wouldn't show expenses there. We have not moved journals out, and it wouldn't pull up as expenses, but I could get you that fund number as well and get you that. Actually, I do have it here if you would like. That would be dedicated fund 44422.
Okay. I appreciate that. Thank you for your answer. My second and final question, several years ago, when there was transition in leadership of DCS, there was a report from a previous director of the agency with recommendations for reforms. Then we had two secretaries or directors since then. Can you update us on the implementation of some of these recommendations as it relates to budget needs? I know staffing was one of them. You highlighted staffing today. You highlighted the issue of placement, that sometimes it's difficult to place children because of lack of spaces and places in the state. So from what is pending from that report as far as reforming DCS to serve our children in Indiana? Is there anything pending?
Senator, I think I'll have to get back to you on that because I don't think there's anything currently pending from that report.
Okay, that's fine. Please get back with me on
Yeah.
that one. My final question, are you aware of any pending litigation against DCS that poses or have like financial threats to the agency or would require a budget consideration from the General Assembly to cover any future legal costs?
I'll speak to that. So we do have, when we do have litigation, unfortunately, I do not have details on any specific case with me at the time. We can go back and get that for you. But we have had to pay for outside counsel. That is included in our expenses that we represented here. At this time, I'm not aware of any major concerns that are specifically tied to
No
a
class
case.
action lawsuits with claims against DCS for millions of dollars, anything like that?
Not at this time that we're not tracking.
Appreciate it. Thank you, Mr. Chair.
Thank you. Any further questions? Yes, Senator Garten.
Thank you, Mr. Chair. Thank you for your testimony and your presentation. I want to focus on, if you could go to your last, I believe it's your last slide. Well, yeah, you're on it. So the growth and the percentage of change, older youth services, 27% up, probation, 19%, out-of-home care, 15%. If we're focusing on those sort of explosions in those categories, can you just help me unpack and understand? Let's just start with older youth services. Help me understand the why the explosion in that particular category.
So I would say for older youth services, we've seen an increase in demand there. So there are more children that have, I'd say older youth, not specifically children, that our providers have been able to identify that are in need of those services. During the pandemic, the federal government gave us funding to increase that program. That funding went away, those temporary increases, but that demand did not go away. So we've seen steady increase in demand there, and we can provide specifics as well, what that's been looking like.
So let me
I
let me ask just a follow-on real quick, because I want to make sure I understand. So you're saying we did a better job identifying folks that had a need, or we now have more folks that have a need? Which one?
I think we now have more folks that have a
Okay.
need, but we also have seen an increase in our number of children who are BEADS eligible over the age of 18, waiting for BEADS services, right? And so I think I spoke to a little bit about that, about how as an agency, we have to serve the kids, right? And so while the child who's over 18 waiting on an adult BEADS bed then is within our system, and we're paying for that service and placement until the waiver or the funding becomes available through the other state program.
Sure.
Which is usually till they're 21.
And so just kind of how do we identify, how do we, older youth services, what does that encompass? How do we define that?
Good question, and it's really complicated, especially in Indiana. So I see it as an umbrella, right? So when you see it anywhere from 16 to 23, because in Indiana, you can be a CHINS, child in need of services, between the ages, 0 to actually 21. A court can retain jurisdiction until they're 21. But if you are in foster care at the age of 18 and you want to voluntarily remain in extended foster care, your CHINS case can close and you can sign a voluntary agreement between 18 and 21 for collaborative care, which is the program. So it's voluntary foster care, basically. Some of those kids live in dorm rooms. They might be in college, right? They might be in independent living, or they might be in a traditional foster home. And then yet we have another category of kids who are extended services up to the age of 23.
So let me go back just to one of my, that's okay, that's helpful. So older youth services is up 27%. And I just want to.
The cost, but not necessarily the utilization.
Okay, so thank you for that, because that's actually my question. So if cost is up 27%, how much is utilization up, and what's the delta there?
I don't have that number, but I'll get it.
Get back to you on that.
And I would actually be curious for that of quite frankly, every category that's up here. Just, I think we've got to understand as the fiscal body, the relationship between utilization being up versus cost being up.
Yep.
And I do have that on hand for out of home and in home, and we can get that, send that through the budget agency to you today.
I think that'd be great. Thank you. That's all I've got. Thank you, Mr. Chair.
Thank you. Further questions? Thank you for your presentation. Next, Department of Health. Welcome, and whenever you're ready, the floor is yours. Thank you.
Can you hear me okay from here, or do I need to move it over? Is it good? Okay. Good morning. Thank you, Chairman Thompson and members of the committee. My name is Lindsay Weaver. I'm State Health Commissioner at the Department of Health, where our mission is to promote, protect, and improve the health and safety of all Hoosiers. To start off, I did want to share with you all that in the last 2 years, we reorganized our agency structure to streamline and enhance alignment across our initiatives, effectively eliminating duplication of efforts. This optimization not only boosts overall efficiency, but also heightens our effectiveness in delivering those services. A key component of this transformation is the establishment of a dedicated commission that is focused exclusively on maternal, infant, and child health. This targeted approach enables us to strategize more effectively in utilizing our funding, ensuring that resources are allocated where they are needed the most. Moving on to our agency priorities, in August 2024, the Department of Health began the process of updating our state health assessment, also known as the SHAW. The previous SHAW was completed in 2022 and was meant to go through 2026, but it does not reflect our new focus on prevention, data capabilities, and priorities with Health First Indiana. The first step in the SHAW refresh included bringing together statewide representatives from partner organizations to work with IDOH leadership to choose and prioritize our state goals and KPIs. The agency is collecting input from a larger stakeholder group currently and to have agreement on those recommended priorities of infant mortality, obesity, access to care, mental health, and substance use disorder. In 2025, stakeholders will reconvene to develop a comprehensive improvement plan that outlines individual entity and partnership commitments to make Indiana healthier. The SHAW will bring together our partners to the table to assist us in fully executing improvements in our key performance indicators, and I will address in more detail. These are our current key performance indicators, and I'll go into detail for each of these. Starting first with our KPI to achieve a reduction in infant and maternal mortality. In 2023, Indiana realized its first reduction in infant mortality since 2019. The infant mortality was 6.6 per 1,000 births, a decrease from a rate of 7.2 in 2022, which is 53 fewer infant deaths. Our 2022 maternal mortality rate also decreased to 90.4 deaths per 100,000 live births, with 72 deaths down from 80 deaths and a rate of 100.1 in 2021. We have worked over the last 2 years to provide more up-to-date and localized data so that our partners can be more responsive and focused in their efforts. We are able to provide more timely preliminary and final infant mortality data, and will move to provide this on a quarterly basis in 2025. We also launched the birth outcomes and infant mortality dashboards, which is an example screenshot you can see here. Those were launched in July of 2024, where our partners can filter by several metrics, such as low birth weight, preterm, Medicaid status of mom, teen births, and breastfeeding, to better identify leading causes and risk factors for individual counties. The Maternal Children and Families Commission is also working on establishing a one front door to connect moms to services, recognizing that our several different named programs, such as My Healthy Baby, Mom's Helpline, Liv's application, all provide unnecessary confusion. While we have done significant work to improve data availability, the stories of these individual babies and moms do matter, and they do result in actionable information. In large part, thanks to the local health departments and Health First Indiana, we have significantly expanded the number of fetal infant mortality review teams since 2023, moving to now covering 71 counties, up from 36. Our statewide maternal mortality review committee continues to meet and review cases, and they identified 271 individual recommendations to improve maternal health and safety. Examples include continuing support of the Indiana Pregnancy Promise Program, recognizing that the #1 maternal mortality cause is overdose. Unfortunately, the number of counties not providing access to inpatient obstetrical services continues to increase, with 6 more closing their OB services, leading to 42 counties without delivery services. As a department, we undertook a comprehensive analysis to uncover the reasons behind the recent facility closures. We have identified several layers of issues, including operational challenges, financial constraints, and shifts in community needs, all which have played a significant role in the closures. Understanding the elements is crucial for developing strategies to address these concerns and improve conditions moving forward. IDOH is assisting in addressing those gaps in perinatal services by providing obstetric emergency training to perinatal emergency department and ICU nurses, and coordinating with EMS to ensure that there is timely transport of those moms and babies. Lastly, in the space of infant and maternal mortality, we have also identified a new threat, with the number of congenital syphilis cases rising significantly over the last several years. Babies with congenital syphilis have a higher rate of stillbirth and death early in their infancy, as well as an increased risk of lifelong morbidity, costing the healthcare system approximately $58,000 per birth. Congenital syphilis is preventable with appropriate testing and treatment. In response, we have created a new provider toolkit, a dashboard for clinicians, and a task force focused on novel strategies. These strategies include expansion of testing and access to treatment for pregnant women, testing at correctional facilities, and outreach to pregnant women through our navigation programs, substance use, and treatment facilities. Moving on to our next KPI, which is to decrease the incidence of preventable injuries resulting in death. The statewide all-injury death rate decreased 6.5% from 2022 to 2023, and the statewide overdose death rate decreased 17.1% from 22 to 23. And furthermore, the overdose death rate in 23 was lower than the preceding 3 years. Unfortunately, the statewide suicide rate has increased 3.7% between 22 and 2023, and has been increasing slightly over the past 5 years. The statewide unintentional fall rate increased 7.9% from 2022 to 23. 2 key focus areas at the Department of Health are unintentional falls and drug overdose. Falls are the leading cause of injury death among Hoosiers 65 and older, accounting for 42% of injury deaths in 2023. They are a leading cause of hospitalizations and emergency department visits in Indiana. IDOH maintains 2 programs related to fall prevention, stepping on and Tai Chi, which can reduce falls by up to 30%. And now, through Health First Indiana, local health departments are also providing programming and working with EMS and Mobile Integrated Health to provide in-home fall assessments. Overdose death is a leading cause of injury death for Hoosier adults under age 65. And although we have seen a substantial decrease of 21% over the last 3 years, more work needs to be done. Synthetic opioids such as fentanyl accounted for nearly 68% of overdose deaths in 23. IDOH continues to implement multiple initiatives to prevent overdose through naloxone distribution, clinician education, and linkage to care programs. In 2023, legislation was passed that established the Indiana Trauma Care Commission and appropriated funding for trauma system development and trauma and injury prevention. IDOH and the TCC developed and adopted Indiana's first ever trauma system plan in August of 2024. You can see we now have much fewer pockets across the state without 45 minutes ground access to a verified trauma center. The remaining white space is a priority of the TCC and IDOH with ongoing discussions in these areas to move forward with trauma verification or improve trauma readiness for those non-trauma centers. Franciscan Crown Point is moving to be a level 2. Parkview is moving to be a level 1 trauma center, which is our highest designation and will be the first one outside of Indianapolis. Schneck Medical Center, Baptist Health Floyd, and St. Vincent Kokomo are also exploring level 3 verification. Another key area for the trauma system plan includes EMS workforce and triage and transport capacity, modernizing the data registry, sharing of data and visualizations, and improving workforce capacity through training and education. Lastly, there is a strong emphasis on regional trauma system development, quality improvement, and of course, readiness. The newly formed Trauma Care Commission met regularly throughout the year since adopting its first ever trauma system plan in August, and are now moving to implement priorities and objectives associated with the following core strategies: comprehensive engagement, accountability, trauma care access, EMS, data and performance improvement, prevention, education, and outreach. The TCC has awarded over $5 million in grants for 11 different projects. Some examples are here. For example, $3 million towards the trauma system development and $1.2 million in the space of injury and prevention programming. Moving on to our next KPI, which was to expand lead testing, screening, and case management. Thanks to support from legislation and additional funding to our local health departments through HFI, we have seen a significant increase in lead testing and case management. We have seen 440% increase in local health departments supporting lead cases, 62% increase in screenings, which is 108,000 kids tested in 2023, a 12% increase in kids under 3, which is our priority age range. Early data for 2024 continues to remain steady at 95% of our 23 numbers through October. Just as an example of how important this lead testing is, you may have seen this or may have not seen it in the national news, but last year it was found that there was lead in certain applesauce brands. And thanks to our expanded testing, increased access and capacity, we were able to identify several of these children in Indiana. And then the Department of Health and local health departments ensured that there was product removal and follow-up for potential exposures. Thankfully, we are making significant strides to decrease tobacco use in Indiana as well. Smoking rates among Indiana youth in 2022 were the lowest they have ever been, with fewer than 2% of Indiana high school students reporting that they currently smoked in the past 30 days, and even fewer middle school students reporting smoking at 0.8%. Furthermore, in 2022, nearly 1 in 10, or 9.2% of Hoosier high school students, and 1 in 50, or 2.2% of Hoosier middle school students reported current use of e-cigarettes. And even though we have this decline in e-cigarettes, we know that this continues to be the preferred tobacco product among youth, and have heard from several schools that they found kids as young as the age of 4th grade using vaping products, which is why it is important that we continue to invest in the space of tobacco prevention and cessation. Vape-Free Indiana is a multi-component approach to reduce the youth vaping support with a $1.5 million appropriation from the Juul settlement. 53% of the funding went to prevention programs such as Catch My Breath, Voice, and Behind the Haze, and the collaboration with the Indiana High School Sports Association Don't Puff This Stuff campaign. Our next KPI is to decrease the incidence of obesity in Indiana. Unfortunately, Indiana statistics continue to worsen for obesity, overweight, lack of nutrition, and physical activity. In 2023, the obesity rate for adults stood at 43.6%. And Indiana is ranked the 7th most obese state of all states in DC, with over 2/3 of our adults being overweight and obese, and trends are continuing to increase in Indiana over the last 20 years. We have made significant progress to have more timely and accurate data for obesity, moving away from the traditionally used, but we know it was proven underestimation, survey data, to now using true hospital data. Obesity is a multifactorial issue that will need a multifactorial solution. We know that about 1/3 of our youth are overweight and obese, and therefore our goal is to keep those 1/3 of youth from becoming the 2/3 of adults that we currently have, we know that are overweight and obese. Since for the first time we have real data about our obesity rates, we have found that obesity rates are much higher than previously thought looking at our counties. For example, our most obese county stands at 51% of adults in that community being obese. We have developed an obesity innovation team that includes outside stakeholders, including local health departments, physicians who specialize in cardiovascular and obesity medicine, to help provide input in identifying evidence-based solutions for a state plan to address obesity. We have prioritized grants to schools, after-school, early care, workplace, breastfeeding, and diabetes prevention, and secured a $998,000 Builders Vision Food Grant for a Food is Medicine program. In other chronic disease activities, something we talk not very frequently about, but the importance of oral health, which does have a huge cost to the healthcare system in Indiana. Through our Hoosiers Give Kids a Smile program in partnership with the America's Tooth Fairy, Indiana ranked first in the nation for the 2nd consecutive year for dental kit distribution, with over 44,000 educational dental kits distributed across the state and delivering 10,000 oral health kits to libraries, ensuring that families have easy access to essential dental resources. Looking at infectious disease and treatment, following the decrease in testing during the pandemic, there has been a post-pandemic testing increase, which did lead to higher rates of HIV and STIs compared to before 2020. However, rates of hepatitis C after reaching a high in 2017 have dramatically fallen as IDOH engages people with hepatitis C into treatment. HIV positivity rate has been stable since 2017, and our retention into care has increased from 72% to 83% in 2023, and HIV viral suppression has increased from 62% to 69% in 23. Additionally, the IDOH team has worked with Kroger in Indiana to expand the Vaccines for Children program to every Kroger pharmacy, significantly expanding access for families. This was a first of its kind program in the nation. The IDOH laboratory also continues to play a vital role in providing specialized testing services that no other lab in the state can perform. These include testing for rabies, food microbiology, emergency response services, environmental response, infectious disease prevention, well water testing, forever chemicals, so on and so forth. We provide testing for many other agencies, such as the Department of Corrections, Indiana Board of Animal Health, environmental tests for the Indiana Department of Environmental Management, and testing for local health departments, as well as private citizens, for a total of 166,000 tests so far in 2024. Another space that we don't talk about frequently, but is under the purview of the Department of Health, is healthcare regulation. So despite flatlined funding, Indiana was one of only 11 states nationwide to meet all CMS Medicare and Medicaid performance metrics for state survey agencies. This includes on-site complaint investigations that must be initiated within 48 to 72 hours. We also provided 371 long-term care facilities with equipment to improve their environmental cleaning and infection prevention practices, and provided approximately $2.5 million in federal funding to train more than 900 students as CNAs and QMAs to bolster a long-term care workforce. Also, as a reminder, the Department of Health is charged to review all healthcare renovations and new builds, for example, long-term care facilities, surgery centers, and hospitals. And whether it is the addition of a single OR room or a multi-billion-dollar new hospital, the Department of Health charges a single fee of $550. Unfortunately, we have seen a significant increase in these replacement hospitals and large renovations, which has recently stretched capacity. I will talk extensively about Health First Indiana, but briefly tomorrow. But I will just say, to this point, it has been a fantastic program. It has changed how we approach our public health service delivery, really focusing on prevention and wellness that is driven from the community level. We have strengthened our partnerships with our local health departments, hospitals, primary health care, and community-based organizations, as well as elected officials and our business communities and schools that have come forward to be a part of this new solution. We are the convener at the state level with our partners and stakeholders to achieve alignment in these priorities, efficient use of fundings, and of course to reduce duplication. It is a large program, and we wanted to make sure that we are fully supporting our local health departments. So we have developed regional teams in the North, Central, South. These teams live in these communities, so they understand the different issues that are arising within these communities and provide data analysis, partnership connection, evidence-based programs and services, and also assist with finance and budget. We're connecting local health departments to one another so they can learn from their success stories. And also, we now see that local health departments are working together to provide services where it wouldn't make sense for them to provide them individually. They are in the process of developing key performance indicators for each county, which will roll up into our state key performance indicators. Also, we now have a new Health Workforce Council that was established earlier this year to develop strategies to identify, address, and monitor gaps in critical health workforce needs. The council is coordinating with stakeholders to leverage existing programs throughout the state to expand our recruitment, training, and placement and retention of health workforce in areas of needs such as rural health, behavioral mental health, obstetrics and pediatrics, adult and geriatric primary care. We are working with entities such as the Graduate Medical Education Board to help provide data so that we can make sure that we are making evidence-based decisions on where our programming and resources go so that we are able to fully develop our health workforce in the areas of greatest need, for example, in our rural communities. And lastly, the Indiana Department of Health has improved our data quality by identifying new data sources and partnerships. We're refreshing our data on a more quick basis and enacting robust policies on data governance and security to inform our decision-making and programming to show a return on investment into our programs and initiatives and all of the resources that we put across the state. IDOH has greatly expanded our data analysis and capabilities in these last few years. The agency has developed several public-facing dashboards for various conditions, such as the before-mentioned birth outcomes and infant mortality, but also cancer, lead, infectious disease, drug overdose, tick and mosquito diseases, and more are to come. We aim to provide this data at the county level when appropriate so communities can focus on their areas of greatest need. And with that, I will change over here to Amy, my Chief of Staff and Strategy.
Good morning. Dr. Weaver did touch on some of our funding priorities from the current biennium, so I will just give a very brief overview of our agency's overall budget and then provide an update on a couple of other programs. So here you have a breakdown of the agency's total budget. I will note this does not include the $225 million in local public health funding that did not come through the Department of Health, but we are providing the oversight and administration of that. As you can see, the vast majority of our agency funding does come from federal dollars, although we are starting to see that amount reduce over time, especially as a lot of those COVID grants are starting to wind down. For our dedicated funds, the majority of these do come from tobacco master settlement funding. And then for our general funds, they are primarily used for agency operations and administrations. You do see a slight increase in general fund dollars specific to some of the efforts the legislature funded in the last biennium around lead and healthy homes, trauma system development that Dr. Weaver mentioned. So we will be working with the incoming administration to determine any funding priorities for the upcoming biennium. You may remember the Health Issues and Challenges Grant Program. This was established by House Enrolled Act 1007 in 2021 and funded by the legislature using federal ARPA dollars. It's been a very successful program and really paved the way for Health First Indiana and how the local health departments are distributing funding and working with their local partners. It was a total of $50 million in funding. We were able to award 165 organizations. Some organizations received more than one fund, which is why you see the 186 awards. The grant funding will end in 2026, so we're working with our grantees to plan for what that off-ramp looks like. In fact, this is a pretty big year for us. About half of our grantees, their grants will end this year, and so even the program that's administering that, we are scaling that down. We have seen some of these programs get picked up by the local health departments using their Health First Indiana dollars. A really good example is lead, case management and support for families that have kids with elevated blood lead levels. And then we continue to connect these grantees also through their health departments to build those partnerships as they plan for the money to off-ramp going forward. So the grantees, I will say, do also continue to engage within their communities and providing key performance indicators. We have a data dashboard on the website with our Health Issues and Challenges grant, where you can go and see some of the outcomes. And what you had up there on the screen too was just a quick snapshot of the services provided against across the different programs and priorities on an average monthly basis. With that, we'll take any questions.
Thank you. Any questions from members of committee? Yes, Representative Delaney?
Yeah, smoking is one of our key problems. Do you have an opinion or knowledge as to the impact of an increase in the taxation of cigarettes on the usage of cigarettes? Is that something we could do that would be helpful?
So there is evidence nationally when there's been a increase in taxes, they have seen a decrease in tobacco use. So I think that evidence is out there, but those decisions, of course, are up to you all and the legislators.
It's up to the legislature, isn't it? Yeah. All right. The second, I've noticed nationally, I don't know about in the state, you talk about these accidents, falls, and so forth. Are we having an increase in automobile deaths and injuries in the last several years?
I do not have that at the top of my head.
I'd suggest you take a look at that because road rage is just the tip of the iceberg. There seems to be a lot of speeding going on in this state, and I'm not sure that we're putting adequate resources into enforcement. How about hospital closures? Are there hospitals that are at risk of closing in this state?
According to IHA, there's 4 hospitals, and this is by a national report, so we don't have them by name, that are at the highest risk of closure. But we know that there's several other hospitals that aren't meeting their margin, so they could be at potential risk for closure in the future as well.
And there seems to be a related phenomenon. I'm going to call it service reductions. You noted that in the context of maternity. Is that an ongoing phenomenon around the state that certain hospitals, while they're staying open and keeping their finances okay, are reducing their services to people?
Yeah, as we mentioned earlier, we did see 6 hospitals stopped delivering babies, so it's something that we're paying really close attention to, making sure that if they do, make that change, that EMS providers, other providers in the community are updated, that there's a plan to communicate to the women where to go to, but also working with them to see if there's any barriers we could help reduce so that they don't have to move to closures. In some instances, it makes sense. They've seen a significant reduction in delivery, so if you're only delivering 1 or 2 babies a week, then you're not going to be able to maintain your skills. And so, in some instances it makes sense. And like I mentioned earlier, it is multifactorial with some of our other hospitals. So it's something we're concerned about and trying to address. Also working with the Health Workforce Council, we have heard from some hospitals difficulty in recruiting OB providers, pediatric providers into our rural communities. We've heard from our OB residencies that they're just not getting training in these rural communities. So that's something the Department of Health can help support, figure out a way, how do we get our training doctors this ability to actually work in a rural community. And there is evidence that supports that if they have that the ability to train in those communities, they have an increased likelihood of actually working in a rural community in the future. So those are some of the things that we're trying to connect the dots with the problem and solutions.
Are we doing enough to increase the number of residencies in this state? Is that something that we could, by putting some money in it, that we could increase the number? Because we have I guess the largest medical school in the country. But I have the impression that not enough of those who graduate are able to get residencies in our state. Is this something we could work on increasing?
Yeah, so, after you finish medical school, you have to do a residency program, and where people do their residency programs, that's where they're more likely to stay. And in fact, here in Indiana, if a student does their medical school and residency in Indiana, 70% likely they're going to stay and work in Indiana. So it's really, we do need to focus on residency programs and, yes, increase the number, but is it the right program in the right place, right? So it's just not number, but how do we get more residency slots in rural communities, even if they're in an urban community, have an urban-rural connection so that those students are getting that the education and making sure it's in the areas of our greatest need. But for example, OB, behavioral health, et cetera.
So there's a focus of the residencies, not just the absolute number. There's some specialties that
That's
are.
exactly right,
We
yep.
can do more good with, okay. And the
Absolutely.
last question, this is kind of futuristic, I guess, but I watch a lot of TV because, you know, when you're into politics, you watch the news. And I'm hearing an awful lot about these obesity drugs, as I would call them.
Mm-hmm.
Is that potentially an enormous game changer for our population if the price and availability of those is changed? And is there something the state could do to accelerate, you know, the utility and the usage of these?
So as mentioned, addressing obesity has to be multifactorial. And there's very few things in medicine where there is a one-thing solution. And as I mentioned earlier, our goal is to keep those 1/3 of kids from growing up to maybe needing to have this medicine, right? How are we doing, the Department of Health focuses is really in that prevention space. Is it going to be a part of what our obesity innovation team is going to look at and what people should be considering? Absolutely. Like I said, it is multifactorial, but there's other things that we need to look at too, right? Like access to good nutrition, if people have access to physical activity, our children being educated on, you know, making good choices, our families being educated on this. So those are the areas that we're focused on primarily.
All right, thank you very much.
Yeah, thank you.
Birthday Porter.
Thank you, Mr. Chairman. Thank you, Dr. Weaver and Ms. Kent, for your presentation. Just a couple of questions, probably just right now. I look at slide number 7, and we've had these conversations, and I've been around for a while in regards to infant mortality rate. I see it's 6.6 for deaths, an average per 1,000 births. But in the African-American community, Black community, it's like 14.1%. And in the white community, it's 5.6%. What are we going to do? I mean, this is a conversation that's been, we know the word as is. Dr. Weaver, you've been around, we all been, therefore what? I mean, we keep talking about it, we're not doing anything about it. We try to do doulas. South Dakota's funded more doulas. And we need to do that. And how can we, I mean, I know back in 1987, 88, someone lost their job here in Marion County because we were above that rate. So, you know, we've been dealing with this for 30 years now. So what do you suggest that we do?
Yeah.
Period. I mean, it's frustrating. It's very frustrating for people that look like me.
So you are correct. The rate of infant mortality for Black infants is twice that of our state rate. So it's over 13%, or sorry, 13 per 1,000 births. What we are doing at the Department of Health, which is different than how we've done things before, is rather than take down the state level or federal level top-down programming, we're going to try and do the same programming across the entire state. We're now, you know, really connecting resources, funding, and programming at the local bottom-up level. So, you know, yes, there's definitely the high rate in infant mortality, but if you go down to zip codes, we have some zip codes where the infant mortality rate is 33. So we're listening to our communities who are telling us what those needs are, whether it is access to prenatal care or substance use, whatever it is at that very local level, and enabling those communities to do something about it. And I think that's where we're going to see our biggest difference. So that's why we've changed how we're looking at our funding. That is why I think Health First Indiana has been so successful in such a short time, is it's really getting down to that very local community level to make these differences for whatever community is most affected there.
And I thank you. And I would say zip codes are good, but census tracts are even better. I would look at the census tract and try to look at from that perspective. I think it's very important also. Also, lastly, Representative Laney, we talked about underserved areas in regards to OBGYN and what's going on. I know, how can we continue to build and help those residents to go to those disadvantaged areas? They're not going. I mean, do we regionalize the hospitals now? Or, I mean, what do we do from your perspective nationally? What have they done to address this? And like you said, we get largest medical school, millions of dollars. Smaller, you know, other universities are going down this road in nursing, et cetera. What do you prescribe as a physician that we can do?
Yeah, I do think we need to think outside the box and not continue to do the traditional way that we've done medicine. And that includes looking at, for example, family medicine OB fellowships. So we know 90% of our hospitals utilize family medicine physicians to provide OB services. Yet we only have one OB fellowship program, and it's up in St. Joe. They only graduate 2 kids a year, and they don't have a very high retention rate. Many of those graduates end up going to Michigan or Chicago. So I would love to implement a fellowship program for our family medicine residents somewhere else in Indiana, hopefully a rural community, so that they can get, fully trained. And that is not to replace OBs, right? This helps make a unit of providers that would be able to provide better care. We know one of the issues is that often these rural communities, they don't have the number of deliveries in order to have several OBs, right? And so your OBs end up taking a significant amount of call, which is the old model. And so we need to consider new models. And that includes doulas and midwives and the entire kind of spectrum of providers to help make sure that we're taking the best care of women and that they have that immediate access to those prenatal and perinatal services.
Thank you, Mr. Chairman. Thank you, Dr.
Senator Kadora.
Thank you, Mr. Chair. Thank you both for your presentation. On one of the slides, page 12, slide number 12, KPIs in regards to promoting trauma and injury prevention, the bullet point before last, it indicates that the suicide rate has increased 3.7. What's driving that?
I'm sorry?
The suicide rate has increased 3.7% in the last 2 years. What is driving that increase? Any social determinants of health? Is it regional in specific communities?
We do have that data. We do see higher rates in our rural communities, and we're able, to break it down even further by age. We now have suicide and overdose fatality review teams, and we're trying to get those in every single county because, again, it changes, right? Is it poverty? Is it access to mental care services? It really does look different in many of these, or is it substance use? What's really the driving factors to, again, allow those communities to make very specific changes and implement solutions at that local level. So trying to increase our number of suicide and overdose fatality review teams across the state, making sure that we make data available, and then I'd be able to more clearly answer
Yeah, I
this
appreciate. I'll be interested in looking at that data. There's another policy area that I'm interested in that intersects with suicide as it relates to public safety, so I'm interested in that data. So if you don't mind, whenever you have that data, I'll be interested in looking at. My second and final question, have you noticed in the last couple of years as it relates to physicians in these specialized areas, are we losing more people in the last couple of years, more physicians, more students upon completing residency, leaving the state, or not even applying to the state? Moving into the state? Have you seen any trends or data on that?
I don't have that data at hand, but we are working with the Health Workforce Council to look at that information to just have a better understanding.
That would be helpful.
Sure.
And then as a final comment, I just want to thank you, and you and Dr. Box played a critical role over the last 4 years leading our state through a very difficult time. So I just want to be sure that, credit is given where credit is due, so I appreciate your leadership and your service and your entire team.
Thank you.
Thank you. Thank you, Mr. Chair.
Thank you. Further questions? Senator Garten.
Thank you, Mr. Chair. Thank you for your presentation. I appreciate it. I want to get back, I guess, to one of the points I think Representative Delaney brought up, and I think Rep. Porter may have touched on it too, regarding OBGYNs in our rural communities, our rural hospitals. So I'm almost embarrassed how many hours I've spent talking to hospitals and IHA about this specific issue. One of the things I keep hearing back from the hospitals is you don't want a doctor delivering a baby that's not doing it enough.
That's right.
And so I think it's important for us to understand what is enough. An OBGYN that's doing this, that's their skill and craft. How many babies do they have to deliver on average to really stay sharp in that space, right?
Yeah. That's a good question. And I would say it's not just your OB, it's also your nurses who
Sure.
are helping care
Yeah,
for
support staff,
those
of
women,
course.
right? And so we have heard that from some of the closures that just their number of deliveries had decreased so significantly it wasn't safe anymore. I don't know what exactly that number is. And it may depend because we do know some of our OBs go to different facilities. So they'll work at a high acuity facility or like where they have a really high caseload and then spend some time in more of those rural hospitals where maybe they're only having one delivery a day. So again, I think this is where we have an opportunity as a state to be really innovative and think differently about how we're going to deliver this care and look to do more models like that where they're getting that high exposure, right, and that high rate of cases, and then, would spend some time in the lower case areas.
Yeah.
Yeah.
No, and I appreciate that, and I think you're spot on. The number that are sort of, I'll say the range that I've kind of been given from the different folks I've talked to is somewhere between a minimum of like 10 to 15 a week. And basically, the doctors that work in this space say, if you're not at a minimum doing that, it's probably not best for the community to continue to have that open, right? Now, I think there's a case to be made too in some capacity that there were financial decisions made. From a hospital standpoint, we could debate those obviously, but yeah, I just appreciated that. I think there's a point there that we need to understand though too. It's not just folks closing these, that there's a real threshold of activity that needs to be met.
Absolutely.
In terms of
Correct.
keeping sharp. So I appreciate you on that. Back to the obesity topic. I want to switch gears on that for just a second. So we're the 7th most obese of all states. I think the last statistic I saw is 51 or 52% of all babies are born on Medicaid in the state of Indiana. I don't remember the statistic offhand of how many families are receiving SNAP benefits, but I'm sure it's probably above 50%, I would assume. What role, kind of a multi-part question here, what role, one, should government play in the obesity conversation? And two, what can we do as a state to do a better job addressing that?
Yeah, that is a great question, which is why we've brought together some experts and some stakeholders in this field to think about that. What exactly would be our role? I will say, as we've engaged our local health departments in this conversation, and many of them are developing key performance indicators to address this space, they are identifying some local issues, and including one county that has a very high obesity, who said, we know that a good part of our community is shopping at a convenience store, right? So how do we get better access to foods there? Another community said they were providing fresh fruits and vegetables, and they found out that the people who they're providing it to did not know how to prepare them, right? And so they had to take that next step of education and including here's the right equipment to do so. So I think from my thought process, right, as a public health focus on prevention, those are the spaces where that is the role of government, right? Making sure, like looking at the landscape, have we built an infrastructure where people who want to access this have access, right? Of course, people have choice, but if they wanted to, that it's there and available, and making sure that that education is in the community, whether that be, through the diabetes prevention programming, which works, again, nutrition, access, education on, how to properly make fresh fruits and vegetables, et cetera. So it's multifactorial, and I think that's where we're providing most of our support right now.
So one of the things I think I've seen, and I don't think any of us have to drive very far to see it, is seems like there's been an explosion of Dollar Generals and Family Dollar stores open up about every 2 miles, especially in rural communities.
Yep.
And I think this was probably in response to what started out as a food desert conversation.
Yep.
Would be my guess. My concern about that trend, and you just hit on it. So now you've got rural communities that are using these convenience stores in a sense. They're, I guess maybe not by classification a convenience store, but probably not specializing in fresh fruits and vegetables. They probably have some to some extent, but so then when you see Hoosiers in these rural communities go in, they're on SNAP benefits and using these things, a lot of times they're walking out with a box of honey buns and a case of Mountain Dew. And we're dealing with obesity issues. Should we, as a state, should we consider classifying different foods and/or vegetables that those benefits can be used for? I know that's largely a federal program, but I think we do have some jurisdiction over restricting some of that stuff. Do you have thoughts on that?
I think, for example, our Food is Medicine program, which is actually, helps incorporate food prescription. So if you're seeing your physician and they're like, we need to address your diabetes, your hypertension, and your obesity, I'm going to give you this prescription for produce because it is more expensive, right? Fresh fruits and vegetables are more expensive. And so would not be surprised people are picking those convenient foods. But also I wouldn't assume that they are educated on what the proper choices are, right? So there's definitely an education component of it. So I think, we're exploring the full spectrum of what we can and we can't do to be able to affect in this space.
So to the education piece of that, I guess that's when I'm a little confused because I think we have a whole part of our K through 12 curriculum specific to really food. And you look at, especially in higher ed, we've got classes now where kids are cooking and all the things, right? So I'm a little lost on that part of it. I don't understand the education side of it, or maybe you think the lack thereof, and that's okay. Help me understand that. How are we missing the mark there compared to other states in terms of education in that space?
I don't know if it's necessarily compared to other states, but I think we need to do something different, right? Because what we're doing isn't working, especially if you see our obesity rate continue to go up, right?
Yeah.
And it's good to educate the child, but if you're not educating the parents, right, and making sure that they have the proper tools to be able to provide that food, then it's going to end there. But you should also be educating the child simultaneously. I think where our local health departments are able to meet people where they're at, they know where their highest risk areas are in their community, and so they're able to actually go into those communities to provide support, whether that be at the Boys and Girls Club. One of our counties is providing funding to connect adolescents who are overweight and obese to get them YMCA memberships where they're going to get nutrition education, have access to physical activity. So again, they're really driving it at the local level rather than me sitting at the state level, saying if we do the same thing across the entire state, it's going to work. We're really helping enforce that locally driven solution.
Thank you for that. I appreciate that. Just one last point, Mr. Chair, if I may. So we just heard from DCS right before you, and they talked about the increase in activity calls, be it neglect, child abuse, all those things.
Yeah.
One of my concerns, especially in this space, and especially to the education piece too, is those are the same households. A lot of times the same households that maybe aren't educated in this food space we're talking about or have kids that actually need food are the same households that we're seeing increased activity in, be it child abuse, neglect, whatever the case is. And so what I have seen in the past historically is a lot of these houses aren't getting what they need because they're afraid to contact people, because they're afraid that authorities are going to be in their home now and they're going to be exposed to bad things that are going on. Is there a way, is there cross-collaboration between the agencies to cut through some of that, to try to still get to the kids that are in need? And can you just expand on that and help me understand that a little bit? I don't know if I'm doing a good job articulating that, but I think there's some
You're 100%
some
correct.
crossover in those same households.
Yeah, the department, Hoosiers deserve for our agencies to be working in alignment to make sure that whoever is connecting with them, whether it be our local health departments, utilizing our state funding that's going to them, DCS, one of our other programs, My Healthy Baby, et cetera, that they're fully aware of the full spectrum of services and they can bring those needs, right? Gone are the days, which is why we're moving, starting with the Department of Health, to where we have a one front door for moms and babies, not like trying to figure out, oh, this program, but you just come in the front door and we'll figure out what you need. And that'll include the work, in prevention that DCS does and also that's FSSA. They should all be aligned and working together. We had duplication of services across our agency and have done a lot of work to make sure that everybody who's working on breastfeeding is now working together, right? So we're not lapping one another. And this is the next phase, is that we need to make sure we have integration between agencies. I agree. Thank you.
No, I appreciate that. Thank you. That's good. Thank you, Mr. Chair.
Thank you. Any more questions? Thank you for your presentation. Next, I believe we have the Department of Education. So go ahead and come forward, please. Dr. Jenner. Welcome.
Good to see you all. First, though.
Whenever you're ready, the floor is yours, of course.
All right, I've officially started my timer so that I don't go over and I can give you plenty of time to ask questions. Great to see all of you. Chairman Thompson, thank you. So today I'd like to walk through DOE's current budget, which outlines our expenditures and outcomes from those expenditures. Following the December revenue forecast, which I believe comes out tomorrow, we look forward to working with the governor-elect and the General Assembly to determine how to appropriately adjust and support education funding ahead. You should know two things we've been very focused on: understanding the return on investment to double down on what works, and reallocating resources where we're not seeing that return on investment. There is a document I believe that you have. If not, I have some extra copies. These are in a one-page form. It happens to be using both sides, front and back. Our focus and deliverables over the past few years, if you could take time at some point to look at those, and I'd be glad to meet with any of you on the specifics, but some of which I'll walk through today. So let's get straight into the budget overview. You know that the majority of our general fund appropriations go straight to local schools as they support student learning, and that includes tuition support, curricular materials, summer learning, and student assessment. And I'm going to walk through each one of these. In terms of tuition support, just taking a look at our current data, we've been very focused, and I think we have to continue to be focused as a state to drive more dollars into the classroom, continuing to increase the average teacher salary statewide. In this period of about 10 years, we have increased as a state $2 billion additional dollars. Presently, the average teacher salary did increase for the third consecutive year and is now more than $60,000. We need to keep moving that number up. One of the ways that the General Assembly did really encourage and require schools to make sure the $9 billion coming from the state goes straight into or as much of it as possible goes into the teacher's pocket is the requirement of 62% or more of tuition support received has to go to teacher compensation. We did have 74% of schools who met that, and that report is linked right here under source 2, and you can go straight to that report and see some districts far exceeded that 62%. When we take a look at the tuition support breakdown, a couple of things I'll point to. Remember the honors grant, which for fiscal year 2024 says NA, that shifted into the academic performance grant, which I'll walk through. I won't walk into it, I will walk through. The NESP dollars, it says NA for 22 and 23, because if you recall, in 2024, we rolled that into the formula amount. I will just highlight a couple of numbers that we do now have for fiscal year 2025, just got them at the end of last week. Our CTE money for fiscal year 2025 is up. It's at $217.8 million based on the funding formula. And the NESP grant is also up. That's for our English learner students at $44.6 million. And again, this is actual expenditures that you're looking at. When we look at, and I'm going to, again, walk through each of these a little bit, the special education grant, you can see, again, where we've been in 2022. We will know the fiscal year 2025 expenditure amount. That will be completed in February because schools report that data to us in December. So just this month, they would have reported that data. This gives you a sense of our special education numbers. And remember, each one of these areas is a formula that generates a monetary amount. So I'm going to draw your attention to a few different areas. Highlighted, developmental delay, we are up about 1,000 students. That's because the state statute changed in 2018. It expanded the age to 8, where it used to be only ages 3 to 5. Autism, and by the way, that's funded at a approximately $2,700 per student amount. Other one I want to draw your attention to is autism. Autism is up about 1,400 students. That is a national trend that we are seeing with autism. That is funded at $11,100 $11,104. Other health impairment is up about $1,600. That's funded at a $2,000 more like a $3,000 amount. And that increase is really due to, we're seeing increased mental health issues, increased anxiety, and increased asthma are kind of the top line there. And all of these are determined by case conferences with parents. Schools can't just determine, that's case conferences. The next line that I'll mention while we're talking about special education, and remember, special education is in the tuition support formula. The special education excess cost is a separate line item from tuition support. But while we're talking about special ed, just want to highlight this. This fund is for situations when a student needs additional support beyond what a school can provide. It's decided in case conferences with parents, and examples include like severe situations where students may receive day services or residential placements. The next one we'll dig into within tuition support is the NESP grant. Again, this is our English learner data. If you take a look at their trajectory, we continue to go up. In fact, the last time I was here, we've gone up about 20,000 English learner students in Indiana. This is probably the most significant growth that we've seen in any of our student population data points. A few cities I'll highlight that we're seeing the highest growth with English learner students: Indianapolis, Fort Wayne, Elkhart, Goshen, Seymour, Columbus, and Logansport. The next that I'll mention also has to do with NESP dollars. And let's see if I can get this to move forward. There we go. I mentioned that in 2024, we were at about 40 million. For fiscal year 2025, based on the formula, we'll be at about 44.6 million. The average per student on the lower side is about $484 per student. On the higher side, it's about $550 per student. I will tell you, of all of our student populations throughout the state, that our educators have done an excellent job moving the needle. The one area that I'm very concerned about continuously is our English language learners and our Hispanic students who have plateaued. The next big area that I'll hit on is the curricular materials. Until recently, Indiana was one of 7 states that permitted school corporations to impose textbook fees on parents. In 2023, the General Assembly prohibited curricular material fees, requiring public schools to provide curricular materials to students at no cost. The reimbursement is a $160 million budget line. Over $159 million went to 395 public and charter school corporations. Just under 900,000 went to about 46 non-pub schools. Remember, our non-pubs, it's only for free reduced lunch students. That's the only group that gets reimbursed. For the public schools, it's all students. Looking ahead to 2025, we've built out a dashboard that will go embargoed to schools in January. It will be a public dashboard to transparently display by school corporation what's our curricular materials cost claims, what's our student cost by grade, and what's the average cost. I think that you'll especially want to see that because we have some schools that are outliers, of course, but we have some over that per student amount. We have some very much below that per student amount. So some schools are getting that funding and they are below that amount. So just want to provide that transparent look. For summer learning and summer school, that's about $18 million per year. This past year, it was amended to allow the State Board of Education to provide priority reimbursement to summer school reading courses. And I want to highlight that because of some data I'm going to show you here shortly. I've talked to some of you offline about this and want to share it very publicly today. The total summer school costs submitted for 2024 totaled around $26.7 million, with 15.7% of the cost reported for reading. When you look at our data, you'll notice the student count. This is a number of student count that we serve. So when you add PE1, PE2, health and wellness, over $4 million of our $18 million is going to that, or is being requested for that. So this coming session, we do hope to work with the General Assembly to allow some additional prioritization. So last year, you allowed us to prioritize reading. In the future, you're going to see us asking to prioritize STEM and some other key courses. This is just a little bit more about the data. More than 360 school corporations, charters, and non-pubs received the funding. Second and third grade reading courses were reimbursed at 100%, and the remainder of the costs were paid at approximately 63.7%. And by the way, our formatting is very, very off. I promise you I do not have multiple fonts and font sizes on my official presentation. So being type A, I just need to flag that. Hopefully the presentations you're seeing are the correct formatting, much easier to read. The student assessment I learned through your pilot. Why redesign I Learn? Well, there were a couple laws that triggered this, but I would say by far the biggest is for years and years and years, teachers, educators have talked about, gosh, we have one end of the year summative assessment that a lot of times students, parents, teachers don't even get that data until May, June, and it's essentially, in all respects, the year is over. So how might we better design an assessment so we have fall, winter, spring, at scale, and we can best triage and support, or teachers can best triage and support our students. There were a couple other triggers for the redesign. Number one is that first law that passed in 2022 to streamline and prioritize K-12 academic standards in core content areas. That triggered an immediate redesign to assessment because you can't assess over what you don't teach. So that was one. And then the other was in 2024 that allowed for the redesign of I Learn from summative to through year. We're the 13th state in the country to do that. A little bit about the I Learn through year. It's being piloted right now. We allowed schools to opt into that pilot. We had about 1,350 schools, or around 75% of our schools opted in. And that has been very beneficial because what this allows is us to learn and make improvements to the statewide implementation as it rolls out in full next year. Let's talk about investing in our priorities in literacy. We've talked about this multiple times. Indiana's literacy rates had been declining for more than a decade, with the exception of 1 year. The pandemic, no doubt, exacerbated the literacy crisis, and in response, Indiana made historic investments supporting current and future teachers to learn and help support the best practices of science of reading. The historic literacy investment is outlined here. You can see Lilly Endowment supported a lot of funding with our current teachers and our future teachers. And then the General Assembly last budget session added an additional $60 million. So it's an over $170 million investment. Here's a look at our longitudinal data. What we're seeing since 2020 is that for the past 3 years, our rates have continued to increase. Last year was the largest single increase since the history of the assessment. Few things that I'll flag. One is we allowed schools to support students in taking the I Read 3 at the second grade, and that provides an on-track progress report, if you will, to parents and families and teachers. This has been one of the most popular moves, I would say, especially from our teachers, because they can get a sense of where a student is much before they take that test at the end of third grade. They now can take it multiple times. I will say this chart on the right side illustrates schools who opted in over that 3-year period. You can see what our state data shows. Of course, the far right column shows the number of students participating. And then you have the sum of the pass and on track is ranges between 59 and 62%. So our educators are really able to focus in on students that may be struggling the most. Of the second grade students who participated in iRead in 2024, 59% passed or on track, as I mentioned. Nearly 97% of second graders who were on track last year passed in third grade. And with the help of the early indicator, 56% of second graders who were at risk last year passed in third grade. The expansion of iRead in grade 2 will be for all this coming school year. And again, we're virtually there with opt-in. When you look at I would say probably our greatest return on investment with funding, it's this one right here. I shared this with you last year and the year before. We learned a lot as a country from the Mississippi Miracle. They were last in the nation in reading, jumped to 21st. They have sustained that. And one of the big things they did was launch literacy cohorts. So we launched our first one in 2022. Today we have 489 schools involved in the literacy cadre. Our goal next year, and we'll probably surpass this, is 600 schools. The big thing here, and again, that ROI, that percentage point increase, is of the schools who were literacy cadre participants, they moved the needle on average 2.5% for students versus those not in the cadre moved the needle 0.2%. So virtually stayed the same. Our statewide increase again was 0.6. So those in the literacy cadre increased 12 and a half times more so than those that did not. This is a quote from an Indiana instructional coach who is a teacher who is working with other teachers. The pairing of these two elements, awareness of what the students need to know, so iRead at grade 2, and how to teach those needs through the literacy cadre, makes it an exciting time to be a teacher. Indiana's early literacy endorsement, that was passed last year, and that is future teachers who are applying for their first license after July 1 of 2025, and then our current teachers have 3 years, July 1st, 2027, or after the renewal period there. To date, we have nearly 6,500 teachers who have already completed it. Over 14,000 have enrolled. This is a really important element because there are a lot of rumors that went around and have gone around. This is the first time I've ever shared this data. We had a lot of different discussion with the literacy science of reading literacy work. Like, how do you affirm that a teacher has that science of reading expertise? And so the praxis was what was decided at the time with the understanding and willingness that we'll look at other options if we need to and as we get the data in. There were rumors initially, and I heard multiple, that 36% passed this test across the nation. I heard 42%, right? Any number. I'm sure you as legislators heard that too. This is our actual data today. Today we stand at a 92% pass rate. I will keep you updated as that continues, but we're tracking that data very, very close. The next one is aligning our educator prep programs to the science of reading. So these are our future educators, making sure they are equipped. Very, very important that we understand if our educator prep programs are teaching teachers using those science of reading strategies. Reviews began into our higher education ed prep colleges this fall. They will conclude in spring of 2026. And the priority was given to educator prep programs that volunteered as well as those receiving poor or failing grades. Also with our educator prep program, Lilly Endowment provided a large grant to support them, and the DOE, we provided a grant to kind of fill that gap between when Lilly's funding started, again, to make sure we are moving as fast as we can with supporting science of reading. The literacy achievement grants, this was outcome-based funding for teachers, instructional coaches, and other school staff who are positively moving the needle. It considers factors such as iRead pass rate, iRead passage rates, year-to-year growth, as well as the school's overall student populations, the percentage of at-risk students. $10 million was allocated to 20,600 teachers, instructional coaches, and other school staff. Investing in other priorities, let's talk a little bit about STEM. We know for certain that professional opportunities in the STEM sectors are projected to grow exponentially. So how do we make sure our students have the greatest access to STEM education, experiences, and learning? First one I'll mention is the STEM Integration Grant. This grant has been a budget line for several years in Indiana. You can see the total at the third bullet there. Approximately $17 million has been awarded to 280 school corporations or schools since 2018. These are done through competitive grants. They're locally designed. There are a number of different ways that schools are implementing this, and for legislators would be glad to pull up that data and even show you your area and what schools are doing with that funding. Another big STEM program alignment is the robotics grant. This provides dedicated funding to establish or maintain robotics competition programs. The General Assembly increased access by allowing public and non-public schools to be eligible for this funding. In the 24-25 school year, we had 137 recipients. This is probably the big story. Maybe if I can flip it's like a good drum roll. There we go. This is probably the big story when it comes to robotics. Indiana hosts the largest robotics state championship in the nation. We have over 300 teams, 1,600 students. If you as a legislator have never been to that, I strongly recommend. It's incredible. There's students everywhere. Typically it's at Lucas Oil. I think they're shifting it out to the fairgrounds. Indiana has over 1,500 elementary and middle school robotics teams. That's more than any other state in the nation. Number 2 is Texas. Number 3 is California. Number 4 is Florida. Indiana's teams make up 15% of all U.S. teams. Next one I'll mention, the David C. Ford grant. That has been a line item for years. Again, I'm going to move through this pretty quickly. A number of usages here: digital learning grant, the parent and family support grant, as well as a digital learning coach grant, and the AI supported alternative education grant is funded through that. And again, based on we're coming up on time, I'm moving pretty quickly, but glad to go back and answer any questions there. Additional investments in the foundations, reading and STEM. One that I'll call out is the Summer Learning Labs. The Summer Learning Labs started here in Marion County. They're free or low cost, all school types, working together on student learning acceleration, making sure we're reaching students with the greatest need, and then fostering the community and school partnerships. Because of the data of what it showed in Marion County, we decided to try, and several cities around our country have actually copied that exact model. We tried, I've got to slow down. This is my accent coming in. It doesn't allow for fast pace. Yes, sir, Representative Delaney, we talked about this before. Indianapolis is where it started. Very positive ROI. So we said, you know what? Will it work in other places in Indiana? Let's try it in rural. Let's try it in another urban spot. Let's see what types of results we get. Quite frankly, the goal here very clearly is if it works in these areas, we will further push to scale. We'll probably consider reallocating some of dollars from other places to continue to support schools and communities who want to opt in. You can see the data there and the positive increases, and that is a pre-post test in both ELA and math that you're looking at. I will tell you, we will also compare those results and study that with iLearn too, that we just don't have that data yet, so that's why I'm sharing this one with you. The other one is tutoring grants for Indiana families. We started and we paid for this through federal dollars, but Indiana Learns was launched because we were hearing from parents and families right after the pandemic especially, like, hey, I'm working 2 jobs. I know my child is behind, and I want to do everything I can to catch them up, but I don't have disposable income to get extra tutoring. So we launched this. It's up to students can access $1,000 per student. Parents and families work with approved vendors. It has really been successful. Over 23,000 students have enrolled. Over 250,000 hours of tutoring has been provided. And you can see all the locations on our state map there. And so again, we continue to study that. Our greatest impact that we're seeing is in math on that one. Investing in our priorities and maximizing the 4 years of high school. Want to point to the academic performance grants. Few things, if you look at the count, that shows you exactly how many students are awarded associate degree, Indiana College Core, dual credit, our various diplomas. You can see that count there. You can see the dollar amount, and you can see the total. This is expected to grow. We continue to see that credential completion going up. And then looking ahead, we hope to align that with the honors and honors plus seals. Tuition support CTE grants. Again, I mentioned at the start of this presentation that the fiscal year 2025 just came in. That number again went up. It's at $217.8 million. I think looking ahead, we have to look at for our budget, how CTE and CSAs align. That was something we heard over and over from schools throughout the state, so we've got to make sure that there's alignment there. Looking at graduation pathways and post-secondary competencies, you know the majority of our students take dual credit. The second is advanced placement. The third is international baccalaureate in Cambridge. This is a line item that supports paying for AP and Cambridge assessment. Students can have a maximum of 3 exams per year. And this really connects to that last slide and something that many people don't know. Indiana is #1 in the nation for students leaving with college credit. Sometimes you may read that it's Idaho. No, it's not Idaho. Let me tell you about that. Idaho, I get real competitive. This is where, like, Indiana, we've got to win. The number that's often out there is how many students leave with college credit from community colleges. From community colleges alone, Idaho is #1, Indiana is #2. But Indiana has a robust 2- and 4-year participation with dual credit and dual enrollment. So that's why Indiana is #1 in the nation with students leaving with college credit. The average student leaves, the average of each cohort ranges between like 62 and 64% of students leave with college credit. And the average is 13.5 credits. And of course, that does include dual credit, dual enrollment, AP, et cetera. Crossing the Finish Line was launched actually when we came in 2021, we ran the data, how many students are really close, within 1, 2, 3 courses of completing a credential of value. Credentials of value that's educational attainment that no one can ever take away in their future, even if they stop out. And so we worked with our school counselors, we worked with parents and families, sent direct letters, worked with Ivy Tech, Vincennes, and launched Crossing the Finish Line. It has saved students and families over $14 million. It served approximately 12,500 students and resulted in 5,400 additional credential completions. All right. I have 45 seconds left. I just need you to know that. That's my bell to bell. It's a constant strategy I'm working on. So I'm ready for any questions that you may have, thoughts or questions.
Senator Mishler.
Thank you, Mr. Chairman. So I just spoke a few weeks ago with the IASBO folks, and one thing that came up was summer school. So, I'm doing the math here. So It looks like 4 million is used for the reading, or prioritized for the reading. So does that mean the other, 22 million is just used for kids that just don't feel like taking the class during the school year and say, heck, I'll just take it in the summer? So they don't have any real need, they just choose to do that.
Whoops.
Oh, time's up. See you
That's
later.
not yours, that's me.
Cutting me off.
So a couple things that I would just say there. So the budget line is 18 million. So you're exactly right. We spend get this exactly right, about 2.5 million on reading in the third grade, another 1.7 reading in the second grade. We prioritized that, funded that 100%. So these other course numbers, we reimburse at a slightly lower level. But I think looking forward, we have to do a better job of prioritizing what we want to refund or pay for or not. To answer your questions, yes, some students may wait until the summer just to take a high school course versus during the school year. So I think moving forward, we have some work to do with this summer school line item at 18 million per year.
So it doesn't necessarily mean we need to appropriate more money. We just need to be more efficient on where we prioritize the money and for which students. Is that what I'm hearing?
That's what you're hearing, and I will need flexibility from you to do that.
Thank you.
Senator Kadora?
Thank you, Dr. Jenner. Good to see you, and congratulations on your reappointment. Look forward to working with you over the next few years.
Thank you.
I'm looking at this document, which is the agency operating account summary.
Yep.
So the largest line item in the budget, which is the distribution for tuition support, is a flat line. When I look at 2024 and 2025, 2025 was $9 billion, 930, 9.3. And it's the same proposed dollars, the first line at the top, and it's the same exact proposed dollar figure for 26, 20, and 2027 fiscal year. Can you help me understand why a flat line? Does that mean that the agency is not recommending any increases for tuition?
I'm so glad you asked that. This is what I was asked to do, and budget is welcome to chime in, is only talk through past expenditures. And why is because I think you're going to see the revenue forecast tomorrow, and with education being about 50% of the budget, that revenue forecast is going to significantly determine what tuition support could be. So anything that you're looking at, Senator Kadora, is not something that I produced. It's probably from budget.
Got it.
I will work with you and Governor-elect Braun to make that recommendation in January.
I sincerely appreciate you, since you are the top appointed official responsible for education in the state. My concern, I can get behind the idea that today this is a placeholder figure until the revenue forecast is official. But my concern is that more of from a policy perspective, I would love to hear your thoughts on that. So several slides have shown the increase in, for example, English language learners. You had a couple of slides talking about special education. When we look at the funding formula, there's also the complexity index, which deals with the SNAP, TANF, and Medicaid students, foster youth. So to me, there's not policy discussion happening today as it relates to the funding piece, as it relates to what is needed to support our students, almost 1 million students in traditional public schools. The idea that under the textbook fees have been underfunded, the $160 million, I spoke with several districts, including at least 4 in my district. The least was almost $800,000 shortfall. The largest was close to a couple of $1 million. So there's no discussion on how much needed for textbook fees. We need more discussion on what is the appropriate percentage increase funding for our schools. And then when it comes to teacher retention, as of today, how many vacancies do we have across the state for teachers? Do you know that number off the top of your head?
I'll have to have them pull that data.
So I think that continues to be an issue. And when I look at the bottom line of the entire agency's budget, we are losing almost $500 to $600 million from the feds, and I assume some of these dollars are the APRA dollars or dollars that came through the pandemic. Most likely, unless we receive renewed dollars from Eli Lilly Endowment that were given for literacy, if I add those dollars on top of what we're losing from the feds, potentially we could be looking at $600 to $700 million worth of dollars that we will no longer have to support additional initiatives. So I would love to hear, maybe not today if you're not ready until the forecast is available, to look at all of these details: increasing number of ELL, an issue with retaining teachers, underfunded textbook fees, and then a recent article that I saw by Michael Hicks, the economist, where he talked about the performance of different types of schools, where he specifically mentioned that the performance of traditional public schools and public schools is higher than students who receive vouchers by the state of Indiana. So I think if we are to be more effective and more efficient with a tightened expected revenue projections, would love to hear your thoughts from a policy perspective, regardless of what the budget agency is plugging in today. Where do we need to be at financially to support your strategies to improve literacy, to support teachers, to fund textbook fees, and so on?
Yeah, thank you for the question. So I tried to jot down several points that you made that I'll try to hit on each.
I appreciate it for that.
Number one, tuition support, depending on what the revenue forecast looks like. And yes, you know a lot more than I do at this point, but we're planning for it to be tight. You will absolutely see me ask for an increase coming up. However, you should also hold me accountable and hold us accountable. As K-12, let's fund what is working and let's reallocate where it's not and put that funding back into what is working. So we're really looking closely at that. Second thing you hit on is the $160 million textbook. That was a fascinating conversation, because there are some folks just like you. I talked to the superintendent and they're like, we're losing money on the textbooks. There are other superintendents who are like, don't tell anyone, but we're not losing any money. We're actually gaining money. So we built the transparency dashboard. I'm just being real with you. We built the transparency dashboard to walk through, like, what is it every single school, charters, traditional public, non-pub, every single school, what is the cost per student every single grade, so that we can really see transparently what we're looking at and can make good recommendations going forward. Third big point that you made is about the supply-demand marketplace for our teachers. So we can, and this was probably a section that my team took out because of time, but we can tell you the number one in the state that we need is special education teachers. Number two is English learner teachers, when you consider the trajectories going up and the number of teachers plateaus, so we have to get more support to close that gap. And then number three is STEM. Part of the budget presentation that I'll do, starting with Ways and Means in January, is walking through some of the return on investment for some of the retention elements, including supporting our current teachers who may want to increase their certification, and recruiting people who may not be teachers who want to get into the field and best streamline that. We've had a lot of success there, and I'll look forward to talking more about that in January.
I appreciate you, and I appreciate your data-driven approach. Over the past 4 years, I enjoyed working with you. You've been always honest with me, even in times when we might disagree on policy, but I sincerely appreciate your transparency, because that's how we can get things done. My question to you, aside from the revenue forecast for tomorrow, do you have a recommendation of what is the need as far as percentage increase to the funding formula, tuition support, complexity index, ELL? And the reason that I ask that question, you presented to us in the education committee when the law that passed that dealt with the retention of third graders. And there was a slide that dissected the types of students who might potentially be at risk of being retained. And we looked at specifically about 7,000 of the 14,000 dealt specifically with the ones with without the good reason exception or
good cause exemption.
Good cause, yeah. But the 7,000 or 8,000 dealt with special ed. Some of them were English language learners and so on. And so when I see some of the slides of increase in population of these students or student categories, is there 20,000 increase in one category of students, what percentage increase in funding for that line item? Or on a very high level, does the department have recommendation such as, for next year, regardless of the budget or the revenue forecast, we think based on need to help us accomplish our goals, we need a 5% increase in educational funding. Do you have any thoughts on that percentage or the amount that is needed aside from the forecast?
So I'll tell you, I'm a big believer. You have to see the data and numbers to understand what that percentage could be. There are a lot of things that I want, both personally and in the education budget, but we have to understand what is the revenue forecast say, what can we look at this percentage being, and then do we put more money in NESP, which is EL, as you mentioned? Do we put more money in special education? I think that's when CTE, the couple of numbers that I did flag are numbers that will continue to increase. And that's in the CTE space and NESP space. We're absolutely seeing that increase continue. Academic performance grant, we're going to see that likely to increase. So all of those projections and recommendations will be ready to go in January.
I appreciate you. You're a friend, and I will hold you accountable because of that professional relationship. And I will hold you accountable to your professional recommendations as we move forward. And here's what I mean by this. I understand that the General Assembly is the policy-making body where they dictate where money goes. I made my opinions very clear that when we went to almost close to universal voucher spending, but we said we don't have enough money to give traditional public schools, and then we complained that the locals are carrying most of the burden by funding our schools by property taxes. There's an inverse relationship here. The more that we underfund public education, the more that we're going to shift the responsibility to the locals, and I don't think that's the intent of the General Assembly. So when I say in a respectful way, I'll hold you accountable, I think it is extremely important when we say there's not enough money in the budget, yet we can expand the vouchers to almost close to 97% of all students qualify for it. But we still don't have universal pre-K, which research and data has shown that the strongest correlation with students being able to complete K through 12 and higher ed is investing in early childhood education. So these are policy recommendations. I think we can debate the nuances of the policies, which papers we're going to look at, which data we're going to dissect, but I urge you to continue to be transparent with the data and push back against us as a General Assembly to say, if you want to continue to fund some of these programs that are not performing as well as these programs, then here's what the result is going to be for our kids and literacy and their ability to graduate on time and all of that. So I know that that's more of a comment, me standing on my soapbox, again, with where I stand with my understanding of public policy as it relates to education. But I look forward to working with you, and I look forward to investing in our teachers and our students so that they can succeed. Thank you.
Thank you.
Thank you, Mr. Chair.
Thank you. Senator Cordero, at least from my understanding, it's school debt. It's where the large growth is. It's not in the operations fund, but that's what my understanding from the data. Thank you. Director Habig?
Can I really quick add, and then?
Yes, you may.
The other thing, you said you'll hold me accountable, and I do think it's a back and forth, because one thing that we'll be looking at closely is the property tax discussion ahead, because it does all connect. We'll be eager to work with you on that, understanding there's some solutions needed there too. Sorry, Director Hagan.
Yeah, Director.
Thank you, Mr. Chairman. And Senator Cordero, just to clarify, I think Dr. Jenner probably stated this better than I can, but the rationale for having agencies present what we term baseline budgets, these are FY25 appropriation levels, is one, because quite frankly, there's past precedents in 2016 and 2012 to do this. We don't have decisions yet on any agency's budget. Obviously, we're in the middle of a gubernatorial transition, and then as she stated too, obviously we're awaiting the biggest factor, which is going to be that revenue forecast tomorrow. So once we have all of that, quite frankly, in approximately 1 month, the new governor-elect's team is going to come in front of this body and present their recommended budget. And then there will be plenty of opportunities, both in Ways and Means and also Senate Appropriations, to hear from all of these agencies again with the actual recommended budget. So hopefully there will be adequate time to review those. We just wanted to follow past precedent.
Senator Niskoski.
Thanks, Mrs. Chair, and Dr. Jenner, thank you for your presentation
Yes, thank
today.
you.
I did notice early, and I know our time, we have questions, I understand, but we're going a little bit past time. Earlier in your presentation, you talked a little bit about the rather large increase in the autism spectrum disorder, and also seeing those same results from across the country. Can you give, is there some based reasoning or study that is showing what is causing those numbers, percentages to go up?
It's a really important discussion. I'd like to pull my team to get more detail as to why we're seeing it on the national level. Some of it is, before I speculate, let me just pause there. But it's a really, really important discussion for our state and for our country as these numbers continue to increase.
Thank you.
Thank you.
Yeah, I appreciate when you can get back with me.
Yes, absolutely.
Thank you.
Thank you. Any further questions? Representative Delaney?
Yes, thank you very much for your presentation. It's interesting that we're in one of these 4-year cycles where, or could be 8, where we don't have the new governor in place yet. But I want to talk about the role of the legislature here.
Yes.
Okay. I got a hint from you that you're willing to tell us in January what you really need, not just what the governor-elect authorizes you to ask for. Can I count on you to tell us that your budget is a trim back, that it is not what you want, and what areas you could use more money for the benefit of our children? Are you willing to do that? Or are we going to see what I've seen in the past? Whatever the governor-elect's budget is, that's the right number. So which is it going to be?
So Representative Delaney, you probably know that going into a presentation, it is hours and hours and hours and hours of work with a team, with the budget, working towards what that number is. And you absolutely, I will confirm, I will tell you exactly what that number is, but I also will confirm, I will absolutely work with Governor-elect Braun to set that number and with the General Assembly to continue to push that number depending on what that April revenue forecast says.
You're willing to push us upward where it's appropriate.
I think we've seen that in the past.
Well, I like that. The second thing is I think you need to tell us where you'd like more, where you think there'd be more, because we have to make our own assessment of this. I mean, the Ways and Means Committee starts the whole budget process. And if we start out at a low number because it's what the governor wants and never have the discussion of what else is needed, it'll be a problem. But let's get down to a specific instance. What do you think our school districts are going to have to incur in the way of expenses to deal with these new diplomas that you have created, the State Board of Education has created? I have the impression that there's going to be enormous admin costs, counseling costs, security costs, insurance costs, transportation costs, recruitment costs. So what's it going to cost our school districts to comply with the new diploma? And where's that money going to come from in the next few years?
Yeah, so this could be hours. I mean, if you have like all day to talk about this, I'm here for you.
I'm warning you what you're going to hear in January.
So, yeah, this is helpful. So let's hit on one of those. Let's hit on that you mentioned, transportation. Transportation to and from work-based learning. How might that look? I think one of the things that we have to think through as a state, but really it's as local communities, is how could we work together to support that transportation? If you're in urban districts, there are some options, whether it's city transportation, what have you. I live in rural Indiana. We have 2 traditional public school corps, 2 non-pubs, 1 charter. Like, how could we even work together to support students to get access to some of this transportation? I think that's a question that we are absolutely going to have to ask and think through. I think like most of this work, we have pockets of success that we have to learn from and then share with others to scale. One of the costs that I do see that we will have, and it's in You'll hear me talk about it ahead. We may look at reallocating some of our dollars to support it, is an interactive data system to support students and families on knowing what their path could be, and also counselors and school leaders in helping to look at that data. I will tell you with all respect, we need that today. Even if we hadn't changed our diplomas today, we have people all the time who stop at the Department of Education like, I don't understand all the different options, right? So that is a huge potential that we could build that out, and we'll work with stakeholders to do that. I mean, literally, like, we could talk on and on, but I think, Representative Delaney, with all due respect, like, we had a year-long of stakeholder feedback with educators, with parents, families, with higher education, with business and industry, with any number of people. And what I see is the most promising in Indiana is that we have all hands in with people trying to think through solution options and how we can best
A critical
set that up.
hand is not in. The legislature is not in.
Well, the legislature.
We passed about a 10-word item saying, look at our diplomas. And there was a statewide controversy, and we're not being asked to approve of this diploma. I, for one, will be asking the General Assembly to look at this, because we're going to own it, we're going to have to pay for it, and we didn't create it, and we didn't participate in its creation. And I think that's a huge policy decision. So I'll be looking at that. Are there any savings in there? For example, if we're going to de-emphasize academic preparation, can we stop or limit the requirement that people take the SAT? A requirement I love, by the way.
Yeah, Representative Delaney.
Cut back?
Yep, with all due respect, though, House Bill 1002 that passed in 2023 required the State Board of Education to pass the new diploma rule.
Yes,
House
it didn't
Bill,
require this
really quick,
particular rule.
if I may, sir.
Yeah.
House Bill, oh gosh, there's so many House bills. I think it was 1143
You got
in that
the right
neighborhood
one.
somewhere. That sunset the current diplomas, and I mean, so General Assembly members have reached out to me throughout this process. Multiple have. Some have spoken at State Board of Ed. Some have spoken in public testimony. I've had many private meetings with General Assembly members. So
That's not how we act. We pass bills. We don't meet in corridors and make side deals. So my point is, I think this is such an important decision with such huge financial implications and academic ones that the legislature needs to look at it. And I think we need to push off the effective date of this so that we're happy with it, A, and B, so that we can finance it. But I think the costs are going to be enormous. The school districts are worried about the costs. The parents are in a state of utter confusion as to who gets what diploma when. So I think that the State Board of Education ran away with what could have been a very simple task.
And I 100% disagree with that.
Well, I understand that. That's
because
why we're
by the
here.
way, Representative Delaney,
let's move on.
as a state, we had to think about how to make the 4 years of high school as valuable as possible for Indiana students. We had communities around the state who were providing incredible access for kids. So I wholeheartedly believe we have to, as much as we can, support more access for experiential learning, credentials of value, flexibility of coursework to get that done. And I stand ready for the next 4 years to support implementation and communicate, as you and I have and others have,
we can talk.
very, very honestly throughout the process.
Do you have a proposal to help those districts which have a poor ratio of assessed value to the number of students? Because that's the problem. Most of these programs you describe, you know, the ELL and the complexity, all they do is begin to make up for the fact that some districts can't generate property tax because they have low value. Are you willing to come up with a new way to help those districts which just don't have the property tax base? So they're going to struggle. They're not struggling because they don't care. They're struggling because they don't have the resources. So are you willing to work on that issue?
There is not any problem that you bring me that I've not been willing to work on for the past 4 years, and I stand ready to continue to do that for the next 4 years. Any problem. Bring it to me, we'll seek to solve it. If we're struggling to solve it, we won't admire the problem, we'll give you solid recommendations.
And one simple question, it's not quite as contentious, I hope. You mentioned...
Well, I mean, you're warming me up, sir. We just have a little bit of holiday break between then, but
All right, we'll get together again, but meanwhile.
I know. By the way, we do get along, for those of you watching. Yeah, go ahead, though.
Problem is when we meet together, her staff comes in, they all want to watch. It's like some kind of a public.
Well, now we have a whole state watching, so go ahead.
I'm bringing
yeah.
more people next time. All right, now back at the simple question, because you passed, in reference, you referred to English language learners. You said something about something is plateauing. It's not the number of people in that category. What's plateauing?
Yes.
The
Okay,
success
so,
rate?
No, well, a couple things are plateauing. So we see our English language trajectory going up, surpassing even the growth that we forecasted. Like, it is really increasing. We see a couple of numbers that are plateauing that we're working on. Number one, when our number of students continues to go up and our number of teachers with that EL certification remains about the same, we have a gap in terms of who can serve the child and how to best serve the child, people who are trained. So we have, and again, I didn't get into the details here, but I look forward to it in January. We have, it's called ITEL, that many of our school districts are participating in, specifically to support getting more teachers who have that training and support. That's one. The other plateauing number that I have shouted from the rooftops, as much as I've talked about the high school diplomas, this one too, is our student achievement with our EL students. Our student achievement with the EL students is plateauing. We're seeing other student populations almost over and over going up, but that student population continues to plateau. And so that is concerning as Secretary of Education and something that we have to keep our focus on. We need these students to be readers and know, the numeracy standards, so we'll continue to focus on that. I will add, we have some spots, some schools who have, who've really seen growth, so we're also trying to learn from them as well. What are you doing to move the needle for our EL students?
I'm happy that we can end on something we agree about. Thank you.
Well, good. I look forward to January. Representative?
Senator Fedora?
Thank you. One last question from my side or comment. I just pulled a graph that was given to us by the Commission on Higher Ed in a recent presentation. Out of every 100 students graduating from high school in the state of Indiana, out of every 100 students attending high school, 13 do not graduate. So that drops from 100 to 87. Out of the 87, 41 do not go to college, to two-year degree or college. So 54% of all Indiana students attending high school never make it to post-secondary education, training, and so on. From the remaining 46%, 7 enroll in out-of-state. So really what that leaves in Indiana, 7 enroll in private university, 8 students enroll in two-year college, and 24 enroll in four-year college. So in total, out of the 100, we have 39% of every graduating student staying in the state of Indiana. My question to you is that as a father of 2 daughters who recently graduated from high school, where I see a break in the process, a significant break that we've been trying to adjust for years that has not got the attention it deserves, even advanced students with 4.0 GPA, they struggle to navigate from high school to post-secondary education. With the most well-educated parents, most driven students, they fall through the cracks because of the ratio of counselors to students and being able to work with them from middle school to high school. So one of the low-hanging fruits that I can't understand why we're not paying attention to, when you have that much of a significant percentage of students, 41 out of every 100 never make it to post-secondary education. 41 out of every 100. Similar to the literacy focus and intensive approach, why not invest in counselors at schools through the policy recommendation, whether it's through the funding, the tuition support, whatever, to be sure that we are reducing the caseload for these counselors so that instead of having 41% of students never attending post-secondary education, we can come up with metrics and say, over the next 10 years, we would like to reduce that every year by 1, 2, 3, 4%. I see it as a broken piece of the continuum of that educational process where students and their families literally need to be handheld through the process. Now, to conclude on that note, I know that the Department of Education, your jurisdiction is between, early childhood up to K through 12, but these students are still in high school as they are as they plan on their transition to post-secondary education. So it's a policy recommendation. I would love to see DOE champion this. And I think with the new structure, a few agencies being lumped under one kind of umbrella between the Department of Workforce Development, DOE, and then the Commission on Higher Ed, I hope that there's some synergies to be recognized as it relates to completing that process and not have gaps or broken pieces of that process.
Yeah, I think, well, first of all, the data that you described is one of several data points on why we had to make the 4 years of high school more valuable in Indiana. It's urgent. You mentioned a number of some students going out of state. What we have today is 53% of our students are going on to higher ed. 76% said they were going to. So right out of the gate, we lose thousands of students who had the plan.
Yeah.
We have business and industry saying we need more skills, communication, collaboration, work ethic. Yeah. We have the military saying of all the students who raise their hand to serve our country, 77% of them are turned down out of the gate because of physical or character standards. And then student apathy is at an all-time high in our country and our state, especially at high school, with last year about a third of Indiana seniors missing about a month or more of school. And what they're saying is they don't see the value. So I wanted to hit that. We have a major challenge as a state, as a country, in determining how can we make those 4 years as valuable as possible for kids and bridge seamless transitions. The high school diploma work is a piece of it. Figuring out what supports need to be in place is a piece of it. You mentioned school counselors. School counselors are incredibly valuable. They're a part of the system. The way school counselors are funded, and we could pull that data as well. We have some schools with quite a few school counselors, some schools with fewer, and of course the funding that the state provides goes to the locals to determine what the best setup is for them. But there are a number of pieces and parts. It's unfortunately not one thing that's going to take care of it, but there are many pieces and parts that will allow us to improve the 4 years of high school in Indiana.
Secretary General, I agree with you wholeheartedly as far as the different conditions and the variables and why the demands by different entities. I think I used the term low-hanging fruit, not suggesting it's the only solution. And the reason I say that is that because, again, from an experience as a parent of children in the public school system, I have seen the detriment when you have, I think the latest statistic that I've seen, aren't we close to almost north of 600 students per counselor in our state? I heard and I read close to 650, 649. So I think we debated in the last two sessions that we are at a crisis level. And I've met with so many in my district and other places where they said, a 50-year-old person who is a neighbor, he told me, had I known today what I needed to do back when I went to school, my counselor didn't have the time or attention, thought I'm not a college kid, and told me you should not, just go pursue something different. So in some instances, some students are, based on their performance in high school, are being either sent to the wrong place or they're just not enough counselors because of the high caseload. And there were several pieces of legislation trying to micromanage how much they can spend their time on students versus overseeing other tasks in the school, overseeing exams and all that. I just think this is an important area of policy that we need to continue to look into. I think it's a low-hanging fruit. We can work on it, but I know it's not the only one. But I look forward to working with you on this. Thank you. Thank you, Mr. Chair.
Thank you. Anything, other questions? Senator.
Aren't y'all hungry? I'm just kidding. I'll go all day. I have my coffee and my water.
Senator Garten.
Go ahead.
Thank you, Mr. Chair. Secretary General, thank you for your presentation. If you could go back to slide 13 that focuses on the EL student population.
Yep, I'm going to have my team go back to slide 13 while I pull it up as well. Yep, you're going.
So while you're getting there, I'm going to go ahead and give you a little context to
Yes.
where I'm sort of going with some of this line of questioning.
Yep, there we go.
So I've been contacted multiple times now in the past couple of months from constituents in my district who came here legally, lawful status.
Yes.
Went through all the hoops, all the, things that we put them through, right? And both of them were certainly distraught. One was probably borderline irate. I didn't know the answer to this question, so I'm going to pose it to you today. Do we track, and we're going to focus on this English learner student population right now because it's what's in front of us. Do we know, obviously this is more than doubled in less than 10 years.
Yes.
Do we know the legal resident status of the students in this space?
So I'm going to give my team a chance to see if we do collect that data. There's your chance. That was fast. Phone a friend. And just real quick, I will say, we are required to accept any student that comes to K-12. We want them to get that education. So I need to say that.
And I'm not
But-
suggesting
Yep.
anything otherwise.
Yep.
I'm simply asking,
The question.
do we track?
Do you know if we get that data? I don't know if we do. We'll follow up with you and get that for sure, that answer.
Thank you.
Yeah, thank you.
Thank you, Mr. Chair.
Thank you. Any other questions? Seeing none, thank you for your
It's
presentation.
been a pleasure. Thank you.
And we'll stand in recess for a brief lunch till 1:11. 111.
111.